participating by Zoom. Given this is a hybrid meeting, the additional ground rules still apply. I will begin the meeting with a roll call of commissioners during the meeting. I ask commissioners and presenters to identify themselves before speaking so that the commissioners and members of the public will know who's talking and have the same knowledge as those of us here in room 100. All commissioners are unmuted and may speak. Public and most staff should self-mute and may not speak unless recognized by the chair. To avoid background noise, I ask the commissioners and presenters to mute their electronic devices when they are not speaking. I also ask the commissioners attending remotely to avoid putting substantive comments in the chat because that can be difficult for those of us in the room to see the comments. MHCC posts documents that will be acted on or discussed at least a day in advance, so members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. Hey, I'll start with the roll call of commissioners. I see Commissioner Bhandari. Welcome.
Yeah.
Commissioner Boyer. See Commissioner Boyle. Welcome. Commissioner Brumbot. I see Commissioner Bazitsky. Welcome.
Hello.
Commissioner Cheatham.
Present.
Welcome. Commissioner Douglas. And I see Commissioner Jensen. Welcome. Thank you. Commissioner O'Connor. Commissioner O'Grady. Commissioner Ojikutu.
Present.
Welcome.
Thanks.
Commissioner Wang.
Present.
Welcome. And I see Commissioner Wood. Welcome.
Present.
Gives us a quorum. Very good. So before we start the meeting today, I want to announce that Janet Ennis, Chief of Special Projects in the Center for Analysis and Information Systems, will retire from the MHCC at the end of July. Janet has worked at the commission and its predecessor, the Healthcare Access and Cost Commission, since 1994. She was the fourth employee at HCACC when she was hired. Janet was instrumental in implementing Maryland's small group market insurance reforms passed in 1994. That effort stabilized the small group market over the next 15 years. She directed the Maryland Partnership Program from 2008 to 2014. That program provided subsidies to very small employers that had not previously offered health insurance coverage to their employees. For the last 10 years, she has worked to further establish the medical care database. In that role, she served as the project manager for the federal grants that funded the expansion of the MCDB and now works closely with Friedman Healthcare, MHCC's program management consultant on the MCDB. Janet is the resident expert at MHCC on Maryland's health insurance benefits and insurance mandates. In most years, she is directing one or more mandate studies requested by the General Assembly. Thank you, Janet, for your many contributions to MHCC and all the best as you transition to the next phase of your life.
We don't see Janet. I know she may be on the line, but I know she's here today. Yeah, today. Okay. Who will materialize momentarily. Thank you. Not retired yet. Yes.
Not yet. Turning to agenda item number 1, approval of minutes. Included in your packets are copies of the minutes from the June 15th, 2023 public meeting of the commission, which took place in person and by video conference. I will entertain a motion to approve the minutes of the June 15th, 2023 meeting.
Someone.
Thank you, Commissioner Boyle. Is there a second?
Second.
Thank you, Commissioner Jensen. We'll take Commissioner Jensen. Is there any discussion? Great. All in favor?
Aye. Aye.
Hi.
Are there any opposed? Minutes are passed. Agenda item number 2. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? With that, Mr. Executive Director, can you please provide us with any updates not included in the monthly updates?
Sure. First off, I want to note that Janet is here. Congratulations on your transition. Next phase of your life. Thank you for the close to 30 years of work with the Healthcare Commission and the predecessor, HICAC. And best of luck. Hopefully, you'll stop by occasionally. Tell us how everything is going in the next phase. So thank you very much.
Thank you very much. Lost track of time and didn't realize the meeting had already
I said
started.
a lot of nice stuff
That's
about you. I
fantastic.
could read it. I could say it again if you like.
It's recorded.
She'll treasure the recording forever. So I just wanted to give commissioners a quick update on the 2022 work group activities. I know that later on today, Tracy DeShields is going to talk about the newly assigned work. But we still have work outstanding 2022 that I'm happy to say is moving along according to plan, and we expect to deliver those reports in their due dates later this fall or in the early winter of 2023. These include, first off, the draft or the recommendations on changes to our oversight of healthcare providers, so that out-of-state healthcare providers could, in some instances, deliver telehealth services to residents inside the state. That work group has been meeting over the last almost nearly a year now, and a draft report has been prepared. We expect to present that at the September meeting. It's not, the recommendations are a compromise among those that would be advocating for more access for out-of-state providers, as well as those who insist that we be more cautious. I think we've hit a good compromise area for those recommendations, and I would expect that there would be some legislation, hopefully not requiring us to do more in this area in the 2024 legislative session. The second area, which has taken a good amount of time on our part, relates to Senate Bill 734, primary care report and work group requirements, directed MHCC to convene a work group and develop a plan for accelerating or raising the level of investment in primary care in Maryland. The thought would be that those requirements would apply both to the commercial market and Medicaid, although the actual thresholds would probably be different, because when we look at primary care spending in the commercial market today and in the Medicaid market today, we see that Medicaid MCOs tend to provide a higher percentage of the total spending in the primary care, partly a function of the fact that many of Medicare beneficiaries are younger or children, and consequently the importance of primary care there is greater. We also have to keep in mind that the benefit package under Medicaid is considerably broader with regards to preventive care services in that domain than in the commercial market. We will be presenting the report to the commission later on this fall, but it's moving along according to plan. And the important thing to understand is that we're to lay out a plan in this particular report. It's not going to be as focused on how much achievement there's been, but rather the plan itself will be the major product that we have to present to the legislature. House Bill 378 passed in 2022 requires us to study palliative care services, and our interim report is complete. That's a process report. It outlines what we've done, consistent with the commissioner's request last month, or perhaps it was in May. You said no draft recommendations. We want to have a chance to review those ourselves. We've been mindful of that in this interim report, and how we are going to meet the requirements of delivering a report to the legislature on the process we've taken and the direction we're going. It's noteworthy that we did get some funding from the National Association for State Health Policy, which is a group that primarily focuses on Medicaid, but certain other broader health policy issues. They're advising the work group in terms of the directions we ought to take in expanding access to palliative care services in Maryland. I think there's a good deal of interest on the part of the new administration on expanding palliative care. And although we haven't shared those recommendations yet with the public, I did share those with the health secretary, but I haven't gotten any reaction from her as of yet. The third area, the next area is our study of small assisted living facilities. That particular study asked us to focus on small facilities with 9 beds or less. That definition of small, we've learned, is the MHCC definition. The definition used by OHCQ, the Office of Healthcare Quality, differs somewhat, not unexpectedly. And hopefully we will reach some alignment of what constitutes small in Maryland. As well as I think the most important thing here is that the legislature is looking for us to outline a regulatory regime for small facilities that would both provide regulatory oversight, but perhaps some technical and administrative assistance to these entities as they deliver care to the senior population. There are about 1,500 assisted living facilities in the state. About 1,200 of them are small, meet the definition of MHCC 9 or under, or 1,200 facilities. So the bulk of the actual institutions in Maryland are small, although the larger facilities constitute the bulk of the actual residents. So many times what we are learning is that there's a feeling that the state's not paying as much attention to these facilities as they might, because that's the impression of the legislature. But they also recognize that layering on top of them the regulations that apply to the large facilities may be overkill, if you will. But there still needs to be a very attentive review, and in some cases, some support, because typically small facilities lack much of the administrative apparatus that are present in the larger facilities. But at the same time, many of these small facilities are treating or caring for patients that have higher healthcare needs, memory care, et cetera. So I think the trick will be to try to come up with recommendations that emphasize the fact that we don't know as much as we should. More data collection will be needed, but also we want to put in place, and it may take it may be a process that will take a couple of years, of how the state should regulate these differently than larger facilities that fall into that category. That is the extent of our work group reports for 2022. As you'll see later on today, Tracy will have a number of activities that are getting started right now that result from the work that was assigned in 2023. One of the strategies that we think about as we move through these reports is, gosh, it's a lot of work, and for the future, we might want to be more aggressive in warning the legislature that we do have a palette of activities that are assigned statutorily, and we can't take on as many studies as you look at the 22 assignments, the 23 assignments. It's going to keep half of our organization pretty busy. The next item I wanted just to bring to your attention is that early this month, we did get a notice from the Office of Legislative Audits that they had completed their draft recommendations or draft findings on the three healthcare commissions, MHCC, HSCRC, and the Community Health Resources Commission. There are four draft findings for MHCC. The first one relates to our oversight of the Maryland Trauma Physicians. We do have some feedback from someone on the line. If you could mute your phone, that would probably be helpful for everyone hearing. As I was saying, the first finding relates to the oversight of the trauma fund. That is a $12 million operation that the commission administers. And they pointed out that we could do a better job of segregating duties between the several financial analysts that are responsible for processing payments. And we did, I wouldn't, in my response, I want to note that although they have pointed that out to us in the past, we have taken action. But it seems like the snapshot of when the Office of Legislative Auditors appears, it's shortly after we've had a termination in the organization, or departure or retirement in this case, which occurred very abruptly in August of 2022. And so one of our key financial analysts that worked on this retired rather abruptly. And we did recently hire a replacement. But during the window of when they were reviewing our activities, they saw only one person. I think it will be subject to some qualifications in our response. The second area was the administration of our user fee. They found a couple instances where we had made a mistake on the assessment. And the other finding they had noted was that we were using the previous workload study. Now, what does that mean? MHCC looks at the assignments that we are issued and categorize them as falling principally activities that affect payers, that affect hospitals, that affect nursing homes and healthcare professionals. We are responsible, we are to update that periodically. In the midst of the pandemic, we did post a notice that consistent with the executive orders of Governor Hogan, that we were not changing our regulations. And it does not appear to me that the Office of Legislative Auditors did take that into account. They did note that the workload study was done in 2016 and 2017, which is, yes, that's correct. We hadn't updated that, but that was consistent with operations under the COVID-19 pandemic, which ended in May of this year. So we don't really think we're out of alignment. This notice was visible to all. We've received no complaints, but it is something that we'll have to work out with the auditors to make sure they're clear about this. At the time we issued this notice, we did clear this with the general counsel for the governor and would expect that would be acceptable to the Office of Legislative Audit as well.
Are we doing a new workload study going forward?
We are going to do a new workload study in the fall of this year that will be implemented for the 2025 assessment. The challenge is that these fractions, 39% of the MHCC budget is attributable to hospitals. I think it's 26 or 27 to payers, 19 to nursing homes, and 16 to the healthcare professions. It's implemented in regulations, so we can't just simply snap our fingers and change this. We have to go through the regulatory process. So although even if we completely accepted everything they said, we couldn't change this except through regulations, and our explanation is we think is consistent with what the direction was at the time.
And if I understand though, their complaint was simply, we didn't update it for the last round of assessments, but those are over and no one has raised a concern. And we will have one implemented for the next round of assessments with the regulation changes.
So our next assessment will be in the fall, or this, right now, for the fiscal FY 24 budget, which will use the same ratios. So that might be a point of contention as we meet with them. There's really not a short circuit around changes to regulations,
Correct.
as most of the commissioners know that it's a 6-month process.
Right.
That's why we typically would bring it forward in December or January of the year and have the regulations in place. Could apply the new fractions in the following fiscal year. So it takes 6 months.
But were there actually complaints or was this just they want us up to date?
They just, are looking at our statute and want us up to date. The third item relates to our contract with OnPoint. That they observed that OnPoint itself had not conducted a SOC 2 security audit, although OnPoint did have a high trust certification, which is judged in the industry as equivalent or better than a SOC 2 audit. We'll have to go back and forth with the auditors on that. Some preliminary discussions we've had did suggest that they were judging that to be, they were willing to judge that as equivalent. This particular finding, however, does not take into account the fact that although OnPoint is a contractor, all of the data that OnPoint handles for the healthcare is stored in the the Amazon Web Services infrastructure, which does have both a SOC 2, multiple SOC 2s, and a high trust certification. So it's a technical finding. It's not clear to me that our friends at the Office of Legislative Audits understood that the data was actually stored in the AWS infrastructure and not on some local servers owned by OnPoint. We'll have to clarify that. There is a technical error that we made, which if we should have modified, added a small amendment to the contract and said we judged the high trust certification as equivalent to the SOC 2, which in our feedback to the auditors, we would say we would change the contract to make it clear that going forward, OnPoint would maintain high trust certifications. And I want to add is that in the industry, the healthcare industry, high trust is kind of surpassing SOC 2 as the preferred tool for judging compliance with privacy and security requirements established either by the federal government, state and local government, state governments, or by industry best practices. And lastly, they did note that some of the contract awards that MHCC made were not posted timely on the MHCC. On the state's procurement website. We have some explanations for that. During the pandemic, that site was redesigned, and it took an inordinate amount of time to get various sign-offs for that. So we're at a stage in the audit where these are draft findings. We have a chance to respond to them because we're administratively part of the Department of Health. The Department of Health actually has to weigh in on, are we going to support MHCC's, suggested corrective actions, or do we want you to take more? So I'm not sharing those with you yet. As soon as we get a final, final conclusion from the department, that we can share them. They view sharing it with the commissioners as it be made public. it's not quite that, but that's what their argument is. And I will be sharing those as soon as I can. At the conclusion, after everything is agreed to, there will be a meeting with the agencies, this is HSCRC and Community Health Resources Commission. That meeting is attended by the executive director and the chair of the respective commissions. So it's we do have a governance committee. There to how many? I would say one additional person is probably appropriate for attending in addition to the chair himself, but all the documents will be shared with everyone. I have one other announcement, and that is that, and I see that she is generously present. Jean Marie Kowal has agreed to serve as acting CON director. We did launch a recruitment drive to fill the position. We did not get any acceptable applicants. Jean Marie has generously agreed to serve for 6 months. We do plan on opening that recruitment again in about 6 months to fill the position. But in the meantime, Jean Marie has agreed to serve that role. Thank you very much.
Thank you.
And lastly, as I think most of you know, I serve on the board of the Maryland Health Benefit Exchange. And as a result of appointments and reappointments, the vice chair of that board phased off because his term had been completed. The secretary asked me to step in and serve temporarily as the vice chair for the board. In her absence, I think it will mostly be in chairing meetings when she's not available. Because I don't suspect it will have any impact on my own workload other than because I attend the meetings anyway. But I wanted to be sure the commissioners knew that. And if you have any objections, please let me know.
Congratulations.
More work.
No objections, Roy?
Okay, that concludes I think, we do have some updates from other members of the staff chair.
I believe, Trustee Lee, you have an introduction that you would like to make?
Good afternoon,
Good afternoon.
commissioners. I am very pleased to introduce our newest member of the MHCC staff, Teresa Brown. I've asked her to put herself on camera, so I don't know if she'll show up or not, but Ms. Brown will serve as the chief methodologist for the Center for Quality Measurement and Reporting. Prior to coming to the commission, Teresa served as a data scientist with the Centers for Medicare and Medicaid Services, where she played a leading role in supporting and restructuring their quality measures management system. She also served as Director of Emerging Initiatives at the National Quality Forum, where she guided projects and initiatives designed to advance health equity, patient-reported outcome performance measures, and digital measurement. As Quality and Patient Safety Manager at St. Agnes Hospital, Teresa managed clinical databases and played a significant role in supporting the hospital's compliance with federal and state reporting requirements, such as CDC's NHSN system, which collects our infection data, and the Leapfrog Group's patient safety rating system. Ms. Brown holds a master's in management of aging services from UMBC and a master's in healthcare administration from the Walden University. We're excited to have Teresa join the team and believe she will play a key role in expanding our outpatient reporting and health equity focus. I don't think you can see her, but
Welcome, Teresa.
thank you.
One other announcement.
Great. Eileen Fleck.
Yes, I also have a new staff member in the Division for Acute Care Policy and Planning. That's Elliot Burkham. He is here today. I don't know if he wants to.
Greeting.
So he'll be a program manager primarily working on the annual hospital survey and then also a certificate of ongoing performance reviews. Prior to joining MHCC, Elliot worked for the Health Benefits Exchange as an audit manager. His responsibilities including overseeing the internal audits as well as coordinating and responding to external audits at the exchange. Prior to that, he also worked as a paralegal and an adult educator. He holds a master's degree from Johns Hopkins University. So welcome to him. I look forward to working with him.
Thank you. Thank you. Welcome. Thank you, Eileen.
Is this question time?
Yes. Okay. I was about to say that. If any commissioners have any questions or discussion, we'll start with Commissioner Jensen. Thank you.
Two unrelated. First is a comment and a slight question at the end. There seems to have been over the last few months, a lot of changes in staff related to retirements and hires. And I would just want to note that to ask if you could just briefly keep us updated as to how those transitions are going, and if you need any extra support, or if it's going great, that'd be wonderful to hear. Second thing is now the time to ask on the CON docket. Just real quick, this looks great. I like it. One question, and that's UM Shore Medical Center. It kind of looks like the last entry under notes is we requested a meeting to discuss financing 6/28/23. It doesn't really.
So tomorrow we will be meeting with the applicant and summarize where things stand. Is that Shore had indicated that meeting with us that they were going to receive $100 million state commitments and had gotten that from the Governor Hogan's administration when it was easy enough, I suppose, for Governor Hogan to make that commitment. But that was not fully acted on by the Moore administration up to this point. I don't want to create this impression that they've denied it. They just have not made the commitment yet. And there are different statements have been made by different elected officials about the likelihood that would be made available. So we're going to meet with them tomorrow. They had a meeting with HSCRC last week, which our center director, Winnie Hawk, attended. I don't think there were any conclusions in that meeting, but HSCRC did, I think, point out some of the challenges with Shore's request on HSCRC, which said they would need additional funding. That would require a HSCRC parlance, a full rate review, which is akin to a financial audit, which reviews cost of the institution. And although the goal of going through a rate review is to get more money, that's not a foregone conclusion. And these rate reviews can actually lead to a reduction in what HSCRC is willing to provide to the facility in terms of rate relief. So there's some uncertainty about HSCRC's action. Surprising to Winnie was the statement that they would act when MHCC had docketed, which I think everyone knows is kind of one step in the CON review process. It's ripe for review. They wouldn't act until we had docketed the application. So one of the purposes tomorrow is to try to understand, what are the hurdles and what are the additional options the health system has for coming up with the 70. The state did provide 30 million of the 100 million, and we want to get some impression of where the other 70 million would come from if the state does not make that available to Shore. And I don't want to say that the state has said no. We don't know that that's been has come forward, but I think I have been executive director for 10 years, and Shore Health has been trying to build a hospital for 10 years. It would be great if we could complete this. They've submitted 3 CON requests to us. First 2 have been withdrawn for reasons unrelated to MHCC. But you know, certainly if you travel on the Eastern Shore and go to Easton, you see this, the state of the hospital. There's no one would quibble with the fact that a replacement hospital is needed. You got to get the numbers right. That's, you know, a challenge with the number of agencies they have to satisfy, but we'll report back to you on where things stand. Hopefully we can report in September that the project is docketed. I'm committed to trying to push this forward because I think the residents of the Eastern Shore do need a new hospital, but it's got to be affordable.
But in all fairness to the governor's office, you know, having been through administration changes, you don't just rubber stamp what I mean, elections matter. You do review everything, even if it sounds like it's a good idea.
Understood.
Yeah.
Great. Are there any other questions?
I appreciate the responses. Thank you.
And I want to recognize, is this the new template that Center for Health Facility Planning and our attorneys put together? So I want to recognize Winnie Hawk and Caitlin Depp for modifying the template. So thank you for that. And we do have an update as well that you've asked us about Bayview. That application has been withdrawn as we anticipated it would be. We don't, at this point, don't know if a subsequent application will be forthcoming. I see Tracy back there telling me to yell, so I'll try to do that. But I would expect that Bayview would have some plans, although perhaps not as ambitious as the $480 million project they had initially proposed.
Thank you. Thank you. Are there any other questions?
This is Casey Boyer. I do have a question, and it's kind of tangentially related to several of the things Ben's been talking about. I've been trying to keep track of the chats site on the memesalert.com, and I've noticed steadily for the past couple of months, despite being past the epidemic, that we still have a number of hospitals that are pretty much consistently are in red, and there's a large amount of reroutes occurring. Is there anything being done at the state level to evaluate this and to identify paths forward to try to solve the problem? It seems extensive throughout the state of Maryland, although the Eastern Shore seems to have it not as much of a problem. Ironically, Easton is currently at red, but the problem seems to be absolutely in the other regions. Over. This is Casey.
So there are 3 crisis flags that exist in the VIM system. Yellow alerts, which means the emergency department is overflown, and they ask that EMS bypass that facility. A red alert, which means that ICU beds are fully occupied, and again, the hospitals ask that EMS not bring patients in need of that care be delivered to that hospital. And overrides, which Tracy, do you know what the definition of overrides are? I think that's a broad definition of ambulance bypass as well. And that is both a plus and a minus in the Maryland system. Because if you look at trends, particularly in yellow alerts, which are our emergency department is too full. We can't take any more patients, take them to the next hospital. That tends to have a cascading effect. And there's a reason why there's no alerts typically on the Eastern Shore, because there's nobody out there to pass these patients to. You can't really have an alert if there's no adjoining hospital or neighboring hospital where the patient can be taken. You have to deal with what you have to deal with. Historically, the alerts, the yellow and red alerts were most common in the Baltimore metro area, stretching all the way from Hartford County down through Baltimore County and into Anne Arundel County. Recently, we've seen a surge in alerts in Montgomery and Prince George's counties as well as and while it's true that there are challenges in the ED oftentimes, we think there's some defensive actions on the part of hospitals to sort of pull the bell, and once a neighboring hospital goes on override, to also go on override so you can control your supply, if you will. That's a conjecture on our part, not empirically documented, but it does seem as though whereas Baltimore metro area has the most hospitals and the most beds of any place in the state, yet historically they were the region that had the most red and yellow alerts. Where we're going with this, a bill was introduced to study ED overcrowding. The bill did not pass, but the legislature asked MHA and MIMS to study the issue again. We've written 2 reports over the last 15 years on overcrowding. Maybe we'll dust off those recommendations. But people point to lots of reasons: behavioral health crises, inadequate beds, poor staffing. It's my opinion that some of the challenges relate to the alert system itself, and you can manufacture a crisis in some instances just by the fact that you're trying to control inflow by saying we're not going to take any more emergency EMS ambulance calls until we get things under control. So that got started yesterday. I think there was a planning meeting, and we'll make sure when Tracy comes up that she provides any additional information that she learned yesterday at her presentation.
I have
Can I
a
just,
more question following up on that. So which one of these alerts is it when there are no more beds in the hospital? Because that's been happening a lot in our area, mainly Upper Chesapeake. People are staying in the emergency room waiting for a bed, or they're being sent home because there are no beds available in the hospital.
For managed, the red alerts refer to there are no managed beds available in the hospital. So I think that the red alerts would be what you look for there. It's not that there are no more beds, it's there are no ICU beds.
Okay, so that's just ICU, but any other beds, there isn't a category that captures that.
We'll have to get back to you.
Okay, that'd be great. Thank you.
Yeah, and I'd be interested in the reports when the recommendations come out and get dusted off, because I note in the mainstream media recently, there's reports suggesting that Maryland has some of the longest ED wait times in the country.
And that's true. Thank God for DC because it's worse there, but Maryland and the district have the worst ED throughput in the country.
And it'd just be interesting to read the report again, because at least particularly in the Baltimore metro area, we have a high concentration of beds per capita. So anyway, just a comment.
but back in the day, prior to Obamacare, there was a logic that said that EDs were being overused as primary care. Did we see any bonus benefit reduction in this problem as we've gotten higher and higher coverage in the state?
So I think, that was one of the hypotheses.
Hypotheses, should we say? Not,
But one thing that happened is that old traditions die hard,
Mhm.
and people, they know they can get care in an emergency department, even though they may have to wait. That's not the case typically in a physician practice. If you don't have an appointment, sitting in the waiting room is going to get you nowhere. So I think the things that I've seen published by NASHB, et cetera, that have looked at this, have pointed out that it did help, but it was not the eureka moment that we had hoped for, that people
not the bonus
automatically
we had hoped. Right.
got.
Good.
I've seen studies that present the same type of data, that lack of coverage was one issue, but a lack of institutional cohesion with what people need is another, right? I mean, how you make an appointment, how you follow, how you get there, blah, blah, blah.
But if you have two contributing factors, you remove one, you hope for a little.
Well, but it's not like one and one where they're equal. There's one which is no coverage, and then there's multiple others that probably outweigh the first one by a fair amount. Is what I'm
Certainly
seeing.
people who promoted greater coverage didn't point to that.
Or-
Chairman, Ken Bazinski here,
Go
if I
ahead.
could. It seems we may, if Maryland's one of the longest wait times in the state, in the country, it seems like perhaps our hospital funding system does not promote efficiencies and, aggressive, timely care of our ER patients. If hospitals have a fixed revenue that varies only by their appeals to a board, it doesn't vary a whole lot based on emergency department revenue, then I can see there's no intrinsic motivation for hospitals to pursue, more timely ER care and higher volume of ER care, as like in some of the other fee-for-service states where, your ER is your lifeline to supply your hospital with the patients who pay the bills for the hospital. So I think that's got to have some impact on it. As I've, been on the floor and in hospitals where, or at least in our hospital, there's, you make more money by cutting costs, not by seeing more patients to a large extent. So just my observation from the front lines and looking at the funding methodologies in our state.
Well, it sounds like it's time for a new study. The other one, I guess, just anecdotally, where I live is, there's been a big upsurge in kind of in the boutique. And so there's just physicians being taken offline as they go into boutique. And so they're not available for, waiting for an appointment is going, 2 weeks, a month, 6 weeks, it just is going out. And part of that anecdotally appears to be kind of providers taken out of the system.
Yeah, I mean, I think that's some areas of the state, boutique medicine's a real drain on access, because a boutique practice will take 600 people per physician, and a typical panel is 1,500. So it's the 600 that can afford the $2,000 or whatever it is the asking prices. They have great care, but the 900 or so that drop off that panel kind of left
Sure.
things by themselves. So
The studies will be interesting, because I expect we're gonna find different answers for, Western Maryland, Eastern Shore, and the Baltimore City area.
Yeah, and this seems to tie in with the primary care workforce study as well, or workforce group.
So I was a little one more study, but this sounds like things have changed enough that there's new factors, new things to be looked at. So this is encouraging.
And it's a post-COVID world. I mean, it's the tenor and the feel and the throughput, and a lot of the things have changed after COVID. Maybe not necessarily intentionally, but staffing issues accelerated. The bed weights post-COVID. I mean, the bed weights for transfers are through the roof, and never had things like that. Well, we did occasionally, but it's to an order of magnitude greater than I've ever seen before, in terms of hospitals being full to capacity and no beds available and so forth. So it seems like something may have changed as the healthcare system recovers from long COVID.
Right, and speaking from my community's point of view, we are slated to have our hospital here in Havre de Grace close within the year. And knowing that Upper Chesapeake doesn't have beds, there's a sense of insecurity for our medical services. And it's throughout all of our medical services. It's impacting. Thank you.
That study, do we have the right stakeholders? And it's not an MACC study, so I guess it's more of a broad question.
So we are, sir, we have one participant. I know you're going to speak shortly, but do you have any, can you tell us what the disposition is of the workforce? Winnie?
You mean its position of the work group?
The ED overcrowding work group.
Oh, we just had an organizational meeting yesterday, so preliminarily, it's too early. We were working on agenda items. Develop the agenda, so I think there's a meeting within the next 2 weeks. And that's more organizational as well. I think yesterday was just meeting with some of the principals that were organizing the effort. So I'll have more to report as it progresses.
Thanks. Okay. If there are no other questions or comments, we can go on to the action items. I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform the chair and state their recusal on the record when the agenda item is announced. For commissioners participating remotely who desire to recuse, they should remain silent, turn off their cameras, and mute their phones. Commissioners here in room 100 who are recused should move to the small conference room. Welcome, Winnie. Agenda item number 3, CON priorities for fiscal year 2024. We'll have a presentation of review and revision priorities to the state health plan. The commission is required to review and adopt the state health plan annually in accordance with our statutory duties. Presenting will be Winnie Hawk, Director, Center for Healthcare Facilities Planning and Development.
Thank you, Mr. Chairman, commissioners. Pleasure to be here today. So this is before you today for your approval. And I'm going to walk you through the priority order and the timeline for updating the state health plan chapters. So this is just an overview, and it'll give you some background on some of the factors that went into the decision in terms of the priorities. Next slide, please. Okay, this slide is essentially a view of the statutory language, the statutory mandate, which sets forth a variety of considerations for the commissioners when we do revise the state health plan. The 4th bullet is the one that's highlighted, is probably the most relevant here. It requires annually, and that's by October 1st, we are to assess each chapter, determine the chapters needing review and revision, establish priorities and timelines, and then publish the changes that are considered necessary. And that would be of course, the regulatory review process. Next slide, please. Okay, this slide essentially summarizes the state health plan chapters in terms of those that are old and outdated, those that have been updated in recent years, as well as those that have been underdeveloped. If you look, it's a lot crowded in this slide, so I apologize. But the dates in parentheses at the end of each state health plan chapter is the date that they were most recently revised, the most recent changes that were published. And you can see that what's interesting is that, I mean, there are things, even though, for example, some of these chapters, like the second one under the first section, old and largely outdated, is the alcoholism and drug abuse intermediate care facility. It was last updated in 2013. However, there was 2019 legislation that has had an impact that puts it, up on the list. So also you can see under the underdeveloped, which is the very last category, you can see residential treatment center services, and you can see the date of 1997 and 2021. However, 2021 was when the psychiatric chapter was updated, the psychiatric hospital services, and essentially all they did was remove residential treatment center services and put it in its own chapter, but nothing was done to change the actual chapter. So that chapter really does go back to 1997. Next slide, please. This slide is intended to give you an idea of how frequently we have dealt with any particular state health plan chapter. It's essentially a snapshot of actual CON applications that have been dealt with in the last 12 years. So it goes back to January of 2011. You can see the high frequency, medium, and low frequency types of CON projects that we have dealt with. Next slide, please. Okay, this is actually it was recently updated from what you received in the mail in terms of the actual CON applications that are in the pipeline as of today, because we had 3 in the first category, but Bayview, as Ben has informed you, has withdrawn their application. So we now have these 4. And there are no letters of intent at this time. Next slide, please.
Actually, just a question real quick. Sorry. Back to the previous slide. So we have these rehab hospital services, residential treatment center services in the low frequency. Sort of anecdotally, it seems like we've seen a lot of those recently. Is there an uptick there or not? It's purely anecdotal on my part, so
I don't think so. I think that if we look at the snapshot of the time period, they're very few. Yeah,
good, thanks.
let's see. Next slide. Oh,
If I could just ask one question, and if you don't need to go back to it, but the previous slide about what was outdated or what was needed to be. Are we considering in that an update to the calculations to determine level of need, or updates to the process and what we're considering when we grant an
I
application?
think it's a complete review of the chapter to see where it's not just one particular standard or criteria. There may be things that have changed. For example, at least the one that comes to mind is the ICF chapter. That 2019 legislation was passed that eliminates, if you're an existing intermediate care facility, you no longer need to, you can add beds with a simple notice to the commission. So that has nothing to do with the chapter. The chapter was just updated in 2019. I'm sorry, I forget the date now. It was updated in, 2013, but the 2019 legislation has made the need calculation obsolete. So sometimes there are things like legislation that could be the factor. Other things, I think you just need to review the whole chapter to see how the market is developing as well. So there could be other factors. So it's a complete review. It's not focused on anything specific.
Thank you.
So let's see. So the pipeline, now we're on slide number, oh, I don't know can we go back to slide number 6, please? How we got to the end. Next slide. Well, just looking at the numbers on there. Okay. This slide, okay. These next 5 slides, essentially, I'm going to walk you through the recommended priorities. And again, how did we decide what category to put a specific state health plan chapter in? It's a combination of several things: the frequency the chapter was used, statutory changes that require updates, and some of them are just the degree of obsolescence and whether or not those services are really needed. So this one is a little unusual. We have the very first priority is 102420, which is the nursing home chapter. And that has jumped up in priority, even though it was last reviewed in 2019. There was 2023 legislation that resulted in a work group that is currently in process. And there's a likelihood to be legislation as a result of that work group. I think that we've seen issues with this chapter as it relates to the threshold criteria within which to file an application or file a letter of intent. That has to do with the CMS 5-star rating system. So I think we're taking another look at I think we're fully realizing, we're getting more information on the impact that has to facilities' ability to improve both their facilities and their environment. So I think that's going to be part of this update. I believe, again, how do we decide what to update? We're going to review the whole chapter, but it was also triggered by a discussion that related to, we have provisions in the chapter that require, if you're going to add beds by a waiver process, for example, you have to eliminate all triple and quad rooms. And that is in only certain parts. It only applies if you're going to add waiver beds. You have to have the room and you have to have the ability to not have more than 2 beds to a room. So all of these issues, a lot of these issues, plus there's issues related to private equity investing and real estate investment trusts. So I think the discussion during the legislature has propelled this to a high priority. You have a question, Commissioner?
No, I'm
Oh,
sorry.
okay. Okay, the next residential treatment, I'm sorry, stay on this slide. The next was, I think this is, because this is what will ultimately get to the fact, this is going to be for the next calendar year, these three on this slide. The next is residential treatment center services. Now, these were previously, again, as I said, they were previously situated in the site chapter. That was updated. These were simply cut and pasted and put into its own chapter, but nothing was done to update the language there. We did have we did recently, I know you're aware, in December, we had the Board of Child Care, and in order to review that application, we had to actually review the state health plan chapter and decide what was obsolete, what was applicable and what was not. So I think because it's been since 1997, there's a low frequency of use. However, there seems to be, there's a problem, and the Board of Child Care application resulted was the result of a grant process at by the Maryland Department of Health to address there's a chronic problem of hospital overstay for children and adolescents that are having behavioral health crises. So I think that could potentially be ongoing. So I think that the chapter needs to be revised to be able to address that problem.
Well, or just when you describe the process of the staff having to sort of make this judgment call as you go through that this is obsolete or this is obsolete, we have a process and.
That's what we had to do.
Yeah, it's, let's move this to the front of the list. and get
Exactly.
it done, right?
It's even though there's been one application in many, many years, I think.
Yeah.
There
We
may.
want to face it again.
Exactly.
We don't know when enough.
Exactly. And in fact, it was interesting because I went back and looked at the 2018 modernization, and what they said at that time, that it was children and adolescents had been discouraged in favor of less institutional settings at that time. In 2018, it was suggested that it was unnecessary to continue CON regulation for these types of facilities. But I think that's changed given these hospital overstay problems. And then sorry.
The hospital overstay problems would militate in favor of encouraging more residential treatment centers.
Well, they're looking for facilities to discharge these patients to, and there are none. There isn't enough capacity. So we've had to, we don't have a letter of intent, we don't have a CON, but we've had inquiries about this type of facility. So I'm thinking we need to get it updated. The next is the alcoholism and drug abuse, ICF, and I think I've discussed that. It's 2019 legislation that the big one on that particular chapter, it's made the need criteria essentially obsolete for existing facilities. Next slide, please. This slide has to do, these are the medium priority state health plan chapters. If you look at the first one there, the hospice chapter. Interestingly enough, that one, it was last revised in 2013, but there was a legislative request to delay implementation, and it actually didn't get implemented until 2016. And I believe the delay period was used to conduct education and research to increase the use and utilization of hospice services. But so we need to look at it. I think that we need to create. There's been a lot of discussion about creating more opportunity for consumer choice, but I think there's a lot of conversations that we have to have before we do anything with that. I think there's a lot of controversy. And then the same with home health. The thing with home health is we're not going to be able to update the need for home health until 2024. So because CMS is in the process of revising its quality measures. So that one got bumped down to the medium priority. Next slide. These are freestanding medical facilities. Essentially, there are no hospital to FMF conversions on the horizon, and then rehab services. Again, it's a low frequency use state health plan chapter. Next slide, please.
Why? I mean, you're not going to know this. Why do you think we have not had any applications for new satellite emergency centers?
I'm sorry,
For the freestanding medical facility services, CON. It's never been used to create new satellite emergency services. That's centers because nobody has applied, correct? I mean, it could be used for that.
yeah, I can't answer that. I have to get back to you on that one. Maybe then, okay, next slide, please.
The counterfactual, right? Why has nobody filed an application?
Oh, I know.
Right.
A hard question, I
But we do
understand.
have, I mean,
I
this,
was like, no.
didn't this come up also with the kind of adolescent mental health kind of, there's nobody in the market. So, you know, but I mean, those are good questions. Why is there no one in the market? Is this a payment problem? Is this just, you know, what is the, you know, because there's the need, well, at least on the adolescent mental health stuff, there's a need.
And, you know, if we brought in the Department of Human Services, who administers these facilities, they would say there's a tremendous need, but it's, I think, reimbursement and reimbursement directly tied to a population that's hard to care for. It's, you know, we've had over the course of the last 4 or 5 years, people that come in, express an interest, and then nothing happens. I don't think the CON process is a deterrent. I think what they're looking at is just a business I can make money in.
Sure. And so does it fall into that category of in the old days with fee for service, I could make money, but now I can't?
I mean, it's
Still
I mean,
effectively
it's
fee for
still a
service.
Medicaid fee for service. I'm not an expert in how these people are, this institution.
But as our nursing home friends will tell you, you know, trying to make it on 100% Medicaid is pretty difficult. Yeah. So, okay.
This is Commissioner Bandari. Can you go back the last slide?
Sure.
So freestanding medical facility services, these are independent freestanding emergency rooms. I really don't know how much these really add value. You know, let me explain. There is a freestanding emergency room in Bowie and one is in Queenstown in Eastern Shore. Anytime patient is sick, they see them there and then transfer to the nearest hospital. So the patient insurance company got double bill. One is the emergency room, freestanding, and then the emergency room, the hospital where these patients go. So I think there is something wrong with the system, you know. They are freestanding. I don't know how much better they are than just a urgent care, you know. Maybe legislator need to look into that, how much value they're really adding to the healthcare.
Thank you.
Thank you. Next
Is
slide,
there,
please.
I mean, that's a good question. Is there any insight on that?
So we did an initial study on in 2008 or 9. I'm not sure if anyone back in the day was here, but we did look at, you know, the scope of services that were delivered at that point. There were 2 freestanding facilities, one in Germantown and one in Bowie, Maryland, what Dr. Bandari referenced. I think we did conclude that, you know, the configuration with both a freestanding emergency department, ambulatory surgery, it was a configuration that did work, but what I would observe, you know, since then is that we haven't seen establishments. We've seen hospital systems trying to downsize. That's what, you know, the purpose is. Pre-pandemic, you know, we don't think we need these beds anymore, but we want to provide an ambulatory campus. There's a lot you can do in an ambulatory environment today. Let us have a nice, you know, modern ambulatory campus that will cover 70. It's debatable what percentage of services can be provided in a freestanding facility. We haven't gone back to look at that. When we did the study, we noted that they were not going to be money makers, but the health systems that proposed them, it wouldn't present a financial, you know, constraint for for the health system that wanted to build them, but they weren't going to be profitable. That was our conclusion then. We haven't gone back to look at them recently, but I don't think that the algorithms on profit have changed all that much. And they do keep a footprint for the health system in those communities. They do provide a range of services, but whether they're ever going to be profitable, I think is an open question. And
Ben, thank you for that. I think the concern is, the name is satellite emergency centers. In my opinion, emergency center either has to be attached to a hospital because many of these patients are admitted, or these should be sort of urgent care because they are not really providing really the services which a emergency center of a hospital provides. And I see day in, day out, it's ongoing. Patients that come here, probably majority of patients are admitted, so they are transferred to nearest emergency room after they are seen at these satellite emergency room centers. Just food for the thought.
Thank you. And I think one of the things, I don't want to steal the headlines, but I don't think we're going to see any more FMFs that result from conversions of hospitals in the near future. Those that have been converted are about it for right now.
It's true. I would agree with that. And so.
Are there, because we've had a couple of them, is there a study to find out whether or not they've been successful?
Since the state of hospital conversions, Commissioner, I don't think that I'm absolutely sure we have not done a study on patient satisfaction, profitability, support in the community. We haven't done anything of that nature. I don't think any of our colleagues across the way at HSCRC have done too much.
Well, and should they? I mean, we're edging up to that line of in this process, we're the government and we don't pick winners and losers. We make sure they have a firm financial, they've got their plans right. We have that. But the idea that is it a good business idea or does it, if it doesn't hurt a patient, I think we need to stay on our side of that border.
We can though, and I'm sorry, because I think Winnie's trying to just talk about the CON when someone applies. But in a number of the areas of our discussion have been, we have a CON and there's nobody applying, but we have a need, or in this case, we have a facility and we don't know whether it's actually helping people the way it was originally intended, that I think are within our purview to look at if you're talking about gaps of care or places where the system, we can't force people to apply for CON, but perhaps we can have a view on whether that is really necessary and is a gap in the care as part of our state health plan, not the CON.
I'm only urging caution in terms of it.
No, I agree. We can't stick, these are good, these are bad, but we could say is the freestanding medical facility, is it working? Or if it were configured differently, would it work better? Things like that.
Or is it adding or taking away from the ER problem, the ED problem?
Going back to the rehabilitation hospital services, the idea that it's a reimbursement issue is the reason people aren't going into it. Isn't that something how could we shine a light on that?
I think that's right. That was sort of what I was getting at, is we may be able to point out some of the things, that probably best refer to Ben on how we would approach that, but.
Yeah, I mean, typically that type of study is triggered by the legislature to ask us to look at rehab hospital services. Are they delivered efficiently? I mean, we have fewer rehab hospitals in many states. It's long thought that it's a function of, although they're not fully subject to the rate setting system, it definitely adds some incentives, both from the standpoint of acute care hospitals and rehab hospitals. Now, the last 2-3 years, we've really spent work on this facility in Prince George's County. Encompass, they originally came to us to build a 60-bed hospital before they they even completed that. They came forward with another CON modification that.
And 10 beds.
12 more beds. Now they've opened, but they're going into a joint partnership with the University of Maryland. I'm not sure what all of that necessarily means, but you know, the rehab has been a forgotten service area in Maryland, principally because the hospitals or the SNFs kind of move into that space typically, and it's generally true that SNFs are going to be a less expensive treatment site for rehab than a rehab hospital. So we may not want to encourage too much rehab when SNFs seem to be adequate.
Well, are you going to have work groups associated with each of these? So I mean, if there is something that the commission feels, you know, you could ask the work group, is there sort of a fact-finding, report analysis that is logical here? You've got the experts on hand, and as part of their getting back to you, you know, yes, you should take a look at it, you know, make a recommendation and say what the main components of that study should look at.
Or if there's an unmet need.
And then you can decide, you know, we have the budget to do it, or is there some member of the legislature that is not very interested in this topic? And now we've got a skeleton of a study.
Shall I move on? I kept. I
Do you
didn't want
remember where you were?
I didn't want to, well, no, that's okay. We're still in the medium priority, and I think this is the last one, and it's cardiac surgery and PCI services. And again, getting back to the questions on why this would be in the medium priority, the Cardiac Services Advisory Committee has recommended some small changes. There's also changes that relate to like the Society of Thoracic Surgeons. And then the other interesting potential development is their CMS has announced that it's reimbursing facilities to do elective PCI in ambulatory settings. Now, I don't think that's allowed statutorily in Maryland. However, I think it's going to generate some discussion. So we need to.
And is that an actual, or is that a pilot on their part?
Is it a pilot? I think it was a proposed.
I think
Rule
it's
change.
restrictive, but
Yeah.
Maryland, our statute would not permit patients to be treated in ambulatory surgery center for PCI.
Yeah.
Or elective PCI, not obviously someone who's having a heart attack.
Don't send them to the AD, right? Yeah.
Well, I just think it's going to generate, so it's something that we have to have on the radar. It's going to generate discussion. It will, you know, how it will impact existing programs, et cetera. So I think it's not entirely, although they're rarely used, I think we need to be looking ahead.
Well, I think that's a good theme overall, because we do have a waiver right now, but that may not be forever. And to be totally out of sync with what the rest of the country is doing, and then all of a sudden we find ourselves, you know, 10 years from now losing the waiver, that could be a rough transition.
Yeah, it does strike me that having refined patient selection criteria, if this were to come to pass, would be the first element enabling ambulatory surgery centers to perform this procedure. Given the thresholds we have established for PCI programs, the fact that we would allow it in ambulatory surgery centers would probably mean that we'd have to have different volume levels, because it's unlikely they could meet the gold standard, which is 200. The get by standard is 100. The trouble is if you're below 100, and if you're going to have a number of different facilities, you know, in established where we have 25 programs in the state as it is, and we have 25 programs because the design principle was that we wanted to have PCI widely available for emergency events for people having heart attacks. So hospitals argued correctly, I think, that in order for us to survive, we have to do elective and primary, i.e. in response to a heart attack.
Right.
So that was allowed, but if you're gonna diffuse that and allow more ambulatory, you'll allow it to spread out even further, you're gonna go down, the volumes are gonna
Right.
probably.
And who knows, CMS maybe, this is all kind of thinking about Alaska and Montana and places like that where you don't have time to get them to anything, to a full hospital. And therefore it's, it's moot to us and we should just move on with the way we do things.
Yeah, I agree. I think, one other thing we have to keep mindful, pay attention to is both for hips, for advanced joints and for PCI, that if you're shifting them to an ambulatory setting, you're going to be able to do that a lot cheaper. And just to the point about the waiver, if we're doing it in expensive hospital settings and the rest of the country is doing a high volume of these services in an ambulatory surgery center, the total cost of care per capita test that we're subject to are not going to look good as we continue to do expensive surgeries in the hospital, and everyone else is beginning to route a portion of them to lower cost facilities. And that's something we just have to be mindful of. Hips and joints are farther along. Hips and knees are farther along than
Hearts.
cardiac services in terms of migrating to the ambulatory surgery center.
Great.
Next slide, please. Here we are on the low priority state health plan chapters. Neonatal, interestingly enough, we did have one CON application this year already, and it was the first one in 12 years. So that doesn't bump it up in priority, but it's just an outlier there. And OB, again, the OB chapter is very old. Again, very low frequency use, but this year we have 2 CON reviews in process. So, and then organ transplant, chronic health hospital services. So, all low priority. And I believe those are the chapters. Next slide, please.
Can we go back just 1 second? The comment that you made is sort of just, the conversation is sticking in my mind just a little bit. And it's absolutely right that we want to find the most efficient, setting in which to get these surgical services done. But we also have to bear in mind that if you want a hospital to be there to take the complications and the procedures that go wrong in these ambulatory settings, and you want a hospital to be there for an emergency, they have to be able to make enough money to stay open. And if you bleed off all of the procedures on which they make money, which subsidize the emergency department and the ability to be there for backup, that creates a pretty big problem too. So when we're talking about pricing, those things have to be balanced out, and that's a really hard conversation.
But I think your last statement is what, if I was sitting at CMS would be the question. Ben makes an argument, which we've heard before, and I assume there's empirical evidence to back it up. Really, you got to do 200 of these a year, 150 is kind of okay, but you want to add this thing. If the rest of the country is doing that and we're not, we should have better quality scores than they do on this procedure. If they're trying to do it out of an ambulance without the kind of ancillary services you're talking about and the ability to kind of take care of these people, our people are going to have better outcomes in there. And so then there's an argument again, money is not the only thing, it's money, quality, and access are sort of the, at the federal level.
In a nonprofit situation, I might say it's, quality access and money.
Okay,
And
however you want to
every-
think about it, but it's one of the few things that both parties agree on at the federal level is those, fee for service is kind of, like a lovely 1964 Chevy, but it's a museum piece. And now we can agree on these are one's going to be a little bit more savings and one's going to be a little bit more access, however you want it, that's why different people are in different parties. But, that's why you do that. But I think that this is an acid test. If the rest of the country is doing this and they have and they have as good, if not better quality scores than we do here with the old 200 minimum threshold kind of a thing. We've got some hard thinking to do about that one.
There's no question about that, but that does not
But I think
change,
you're
that
good.
that
I
does
think
not
you have a-
change the fact that when we're having these conversations, we can talk about
Right.
I don't know that we have to keep these procedures in the hospitals, but I do know that we have to find ways to keep the hospitals doing the volume they need to be able to provide the backup they need for the complications in these surgical centers, number one. And number two, the money that they need to keep the doors open to provide the services that nobody else is going to or be able to provide. You know, a burn center, there's not going to be an outpatient source of it. And so there has to be that balancing, and I just didn't want that conversation to go without that balancing part.
As a friendly amendment, the way they prove that is through quality. And if they can't prove through, then you need to look at reimbursement for burn. But this sort of clearly.
I'm not sure that.
But the feds are not this sort of fungible money, you know, yes, you overpay us here, but you underpay us here. I just don't see that as having a lot of support as the trust fund.
We
goes down
have
and
to
down.
find a way to build that into the conversation, and if that little.
Or get your measurement right in terms of pay for what you actually get. Pay the right amount for burns, pay the right amount for transplant. Don't make it that it's got to be kind of a loss leader to help your.
Are you saying the same thing, though? I think Commissioner Jensen is saying that you have to look at how we fund the ER if previously the ER was subsidized by other services and those services leave, you have to look at how you.
That
fund the
is.
ER.
That's why I said it's friendly
That is what
amendment.
I'm
I'm not
saying.
disagreeing with anything he says.
That is what
I'm just saying that the reality is it's not going to be because the hospitals say so. It's got to be, they got to be able to.
And I absolutely was not suggesting that. I'm just suggesting the reality is all of our constituents are going to be deeply concerned and upset if hospitals close because everything that they make money on is taken away. And what they're left with are things that they can't get reimbursed for at a level that keeps them in business. If we don't have a place to deliver babies and take care of burns and have an ED, people are going to, it's going to be a big problem. And that gets skipped over a lot of times when we do the small focus on this. Can we move this procedure out of the hospital? Okay, I'm all in favor of doing it as efficiently as possible and getting the highest quality scores. My entire time in healthcare has been focused on quality. I support both of those, but we got to keep an eye on the other one, and it has to be part of the conversation all the time, I think. Particularly in Maryland, where every hospital is a nonprofit entity. That's why I put the money at third in Maryland. And I understand we have a federal system that isn't that way, but that's the world that the hospitals and their administrators and the boards have to operate in.
Okay, next slide, please. We're done there. This is a timeline. If we're done this conversation.
Yeah.
Okay.
Thank you. Yeah,
I think-
I appreciate you letting me take the conversation back and sideline it for a minute.
No, we can go back to that slide if you'd like, but this is a timeline. It pretty much aligns with the previous slides, high, medium, low priority. And so that's our ambitious goal of in calendar year 2024. And I started 24 because that's the work group, the nursing home acquisition work group will wind up, that report will go in December. And so we can start. Those are the priorities for 04, 24, 25, and 26. Next slide, please. I think it's did I miss a slide?
Was it? I think that's.
On the printout, there's one more.
There's one more slide.
Update on
Oh,
status.
this is it. Okay. No, go back. That was it. So this is just to give you an update on the regulations that are in process. This is an update on the status of the procedural regulations, 102401, that we've been working on for quite some time. Those went to the Maryland Register on July 14th. The 30-day comment period will end on August 14th. And we will sit down and go through all of those comments, and we will then, depending on the comments, we have three options. We can either adopt as proposed, adopt with non-substantive changes, or we can re-propose with substantive changes, and then that draft would come back to the commission. So if we don't have to make substantive changes, I think my fingers are crossed, by the end of the year, we'll have new procedural regulations. And then the other set is the General Hospital Services Chapter 102411. We have reviewed the comments, we're finalizing that draft, and you should see the next version of that at the September meeting.
And you think on the procedure, you'll be back to us by September?
No, oh
Right.
no, I think,
Now, does that hold you up in any of the other movements you're doing, or you'll be in work groups and other things like that?
no, this,
Okay,
no, this is good. I mean, I think we're close on the procedural regs. But what's interesting, what we keep doing now is we have whatever the matter is that we're dealing with. We're looking at the existing regs. We look at, did we change this? And we're sort of trying to respond in a way that is in alignment with that. So I think I hope we have them by the end of the year. That's my hope. So, but yeah, you won't see them.
My concern was just that if you didn't have them, did that somehow bottleneck the rest of your work?
Not at all.
Okay.
Not at all. But that concludes my presentation.
Thank you.
I had one question. Looking out ahead at your timeline for 24, 25, and 26. You're planning to be able to do about 3 of these a year. I think you have 16 if you include the procedural regulations total. That should mean that if you proceed at that pace going forward, about every 5 years, you're able to review each one of these regulations. Are we looking at putting these on a schedule so we don't have to come back and say, well, this is 12 years old, where we just keep doing 3 a year on a rolling basis, and therefore nobody gets more than 5, 6 years out without having a review?
I think that this process can be improved upon, and that's part of something I'm looking at as, new person, fresh eyes in this position. For now, this is what I have out there. It doesn't mean it's going to stay that way, but because I think sometimes we need to update. It's a small amendment to conform with a statutory change. And so why does that have to wait for a complete overhaul? I don't think that has to proceed like that. So we're going to be looking at that.
Well, isn't
I
all,
was trying not to be prescriptive as much as suggesting that once we get through the round of 2026 and we've looked at all of these, perhaps there should be some kind of planned cycle for, great, they're all relatively new now. How do we keep them fresh without waiting 12 years for anyone?
but won't the same staff have to do the CONs? So we're in a situation where, if all of a sudden we get a bunch of CONs in, they're gonna turn, presumably, that's our priority. You put this stuff on the shelf until you can get back to it.
Yeah.
So I would have on it, you probably want the managerial fungibility to know if it's, we've got 5 CONs, give it, take care of it, then we'll come back to it. Especially if you have this sort of low priority where you go, these ones, if we don't get to it for a few more years.
But aspirationally, that idea of having a process, to keep moving through would probably be a good idea. So that's the default. And then if you get a bunch of CONs, then you can back off.
It will be after my time, but right in charge, I would say I would like to have a plan. And then if there's a deviation from the plan, I'm happy to hear about why that was necessary, but it doesn't mean we shouldn't have a plan.
Well, in relation to earlier conversations, you could make sure we adopt a very aggressive plan and give it to you to implement.
But you're gonna have to review them manually anyway. That's the statute.
Create a moratorium on dealing with CONs and more
That's right.
importantly, the determinations, which are
Oh, my goodness, yes.
the work.
Yeah.
Which is telling people a CON is not needed.
It's true, yeah.
We'll have a few thoughts about that. If we say,
Yes.
can't do that because we're doing a plan. Not sure that would work.
Right.
Really.
Our bureaucratic work
operating
comes
pretty-
first.
Operating a pretty thin margin here in terms of staff.
Mhm.
Yeah.
We already talked about studies that get assigned to us. CONs and that.
Self-imposed.
So the plan is here for your approval.
Great.
Just,
We need a money.
and so what people are voting on is the projected timeline. Is that correct?
We have a quorum.
We did.
So do I have a motion to approve the CON priorities for fiscal year 2024? We're only voting on.
Don't move.
Second.
Okay, those. Commissioner Grady and second by Commissioner Jensen. Is there any discussion or question? Great. With that, I'll call the question. All in favor?
Aye.
Hi,
Are there any opposed? Yep, 2024 plan is approved.
Thank you.
Agenda item number 4 is a presentation on Maryland Healthcare Expenditure Report. The Maryland Healthcare Expenditures Report is one in a series of annual reporting on healthcare expenditures using the Maryland Medical Care Database, MCDB. This yearly reporting is required through a legislative mandate. The report provides estimates of personal healthcare expenditures for all Maryland residents, insured or uninsured, for calendar years 2017 through 2020, including funding to support healthcare provider organizations during the COVID-19 pandemic provided by the federal government via the Coronavirus Aid, Relief, and Economic Security, or CARES Act, and the Paycheck Protection Program and Healthcare Enhancement Act. This analysis uses data from various sources, including the MCDB. Kenneth Yates Trotman, Center Director for Analysis and Information Systems, will present an update. Ken, you have the floor.
Thank you, Mr. Chairman. Good afternoon, Commissioners. Before we get started, I just want to make a general comment, introductory comment on this report. We released this report on Maryland healthcare expenditures as a first effort, as we haven't done this in several years. As we are resuming this type of reporting, which the Commission had done a long time ago, and we're pretty good at it. What we have learned at this point so far is that some of the past data sources are discontinued completely, while others are not as valuable as they once were. We are trying to conduct this study in a considerably reduced budget, as we have spent approximately $200,000 to $300,000 in the past to create this report. Next slide, please. The Maryland Healthcare Commission is required through legislative mandate to report annually on healthcare expenditures using the MCDB. This report is one of a series of reporting that satisfy that mandate. This report provides information about total and per capita personal health care expenditures by Maryland residents in 2020, and the distribution of these expenditures by type of service and care source. It compares expenditures in 2020 with those over the period 2017 through 2019. It also compares spending in Maryland, spending nationally. All expenditures are measured. All expenditures measured personal healthcare spending annually by type of service delivered and are in nominal terms, meaning that there are no adjustments for inflation made to these results. The population used in this study include all insured members and the uninsured. Data used in this study come from a variety of credible sources, 7 of them, including National Health Expenditure Accounts from CMS, Maryland Hospital Caselinks data, and the NCCP, to name a few. Data exclusions include here is government administration, state and federal, net costs of private insurance, which includes administrative expenses, changes in reserve of IBNR, contributions to reserve, which is profit or loss, rate credits and dividends, and taxes. Also excluded the public health activities, except for COVID-19 related activities. Also excluded the investment, which includes research structures and equipment. Next slide, please. In 2020, Maryland residents spent on an estimated $69.5 billion personal health care, including hospital care, professional services, prescription drugs, nursing home, and COVID-19. As you can see here, that this is an increase in spending of about 12% from 2019. The share of these expenditures in 2020 show that hospital and professional services, including dental services, make up the bulk of spending, contributing to about 2/3 of the personal healthcare expenditures. Prescription drug comes in at about 8.5% of the spending, while nursing home and COVID-19 related services made up about 6.2 and 5.6 respectively. Next slide, please. This exhibit slide, we compare Maryland's rate of growth, total healthcare expenditures and populations to those nationally. Please note that in this report and this presentation, when we are comparing Maryland's healthcare spending, whether we're looking at it total or on a per capita basis with results nationally, we excluded the COVID-19 related expenses so that we could make an apple-to-apple comparison. Looking at the exhibit on the left, box. The rate of growth in total spending for Maryland increased at a faster rate between 2019 and 2020, or 3.4% to 5.8% than it did nationally, 5.1 to 5.8. Except for a dip in 2019, growth in total personal healthcare spending increased substantially in Maryland over the period 2017 to 2020, and was about 1.8 times what it were in 2017, looking at 3.3% was 5.8% in 2020. Looking at the exhibit on the right, population growth, Maryland changes in population, albeit it lower than the national, and decreasing pattern of population growth follows closely that of the nation. For example, between 2018 and 2019, population changes for both Maryland and the nation were flat. As you can see here, it's about 10% from 2018 to 2019 for Maryland, and about 0.5% for the nation. Lastly, as personal healthcare expenditures increase, for both Maryland and nationally, we see that the rate of change in population increases over the same period from 2020, from 2017 to 2020.
Yep, can I ask a question? In terms of the left-hand side, have you already done that? Is that per capita? So you've already you've controlled for changes in population?
No, that is just pure dollars.
That is pure total dollars spent.
If I show them separately, I show pure dollars on the left.
Yep.
And just the change in
So-
enrollment.
So our takeaway on these guys is population didn't really change a lot, at least the same slope as we saw for the rest of the nation. But what looked like savings that we had short-term 2019 were gone by 2020. And you're comfortable that you've effectively excluded COVID?
Well, COVID is included in these numbers, right?
Oh, it is?
Yeah, because.
Oh, I thought I was trying to figure, before when you did your
Oh,
kind of what's
sorry, no.
included, what's excluded. I
I'm
thought,
sorry, I am.
but if COVID is in here, of course, then the increase.
I think it'd be almost impossible to take COVID out to figure
Yeah,
out.
I am.
Well, that's why I was gonna, my question was gonna be how comfortable, how confident are you that you get it all out, given other things related and
When I'm
messy
comparing-
COVID was?
When I'm comparing to the nation.
Yeah.
Dollars, I'm not gonna include COVID-19 because I don't have the nation results for COVID-19.
Got
I
it,
have it from Maryland, but so I want to compare apples. to
got
apples
it.
here,
Yep,
right?
perfect.
So COVID-19 is not in those dollars, but in the first slide that we talked about, where for the $69.5 million, did include COVID-19.
Mhm.
So the previous slide it's obviously COVID. Dollars.
Why there is a decline in the population? Can I go back? I'm sorry. Why is there a decline in population?
There's not a decline, there's a slowing of the growth of the population.
A growth.
I believe we had quite a tough immigration policy at that point. Close to southern border, that sort of thing. So we still grew, just not as much as we had in the past.
In 2020 looks like 0% growth.
I'm a little afraid to see the 2021 numbers because the experience we were seeing actually was people stopped getting medical care unless they were actually, needed to go to the hospital.
Right.
Part of 2020, and then costs came roaring back in 2021. So it'll be very interesting to see how 2021 looks at these numbers.
Yeah, do you have
Actually,
I don't want to jump to that, but do you have a notion when you'll be able to fill in the, I know that data certainly must have been chaotic during the pandemic, but do we know when you'll be closer to give us 2021, 2022?
I think later down in the year.
Another year? Okay,
Well, later on in this year, as some of the information.
Okay.
To revise this.
yeah,
But as I said, this is the first swipe, the first start.
Yeah.
To resurrect, this reporting as we have done in the past.
yes,
So we're gonna use this as a baseline, to improve, talking to our state partners. To tighten up these numbers, but most of this information is from the National Health Expenses.
is it too much to have a takeaway here that Maryland, although they looked promising in 2019, by 2020, any savings that they may have had compared to the rest of the country were gone? That riding that data a little too far?
In mind is that the way the hospital system worked in Maryland because of the global budgets,
Right.
that acted as a buffer for hospitals in particular because their global budgets were still intact. Now, they were given some leeway, kind of banking global budget dollars in 2020 when utilization would support those global budgets. But during the pandemic, it was viewed as,
Okay.
we ought to have.
Yeah, I don't want to run too far, too fast. with
Everyone ought to
that.
have a
Right.
GBR because it was like, it's kind of like the agriculture business where you take land out of production but still get paid for it. That's kind of what happened.
Yes. But I do remember when they were explaining about kind of the effect, as we move from only hospitals under the waiver to the full system. The graphs at that time, not Kenneth's, but the other graphs looked like, the old pig in the python, you squeeze down on hospital, but the other spending areas. So did you really save any money in the overall system? And I think that was CMS's point. We need to go to all services, not just hospital services. Okay, but I'm sorry for interrupting.
Next slide, the fifth slide. The fifth slide, please. One more. Thank you. All right, so on a per capita basis, which accounts for changes in population, now we have the changes in population. Healthcare spending in Maryland showed some volatility, as we can see here, compared to national results from 2017 to 2020. However, by applying some data smoothing, using the 3-year moving averages to help reduce the effect of these short-term fluctuations results show that spending in Maryland remained below the national results from 2017 to 2020. These results are shown actually in the appendix. I'm going to show them here.
Mhm.
Good. Look at that when we come to the end of the presentation. Also, in this exhibit shows that the ratio of capita spending in Maryland to that nationally is constantly higher in Maryland. The gap increasing over time from 107% in 17 to 106%. Next slide, please.
When, and I'm sorry, because this does the rate of growth of percentages. Looking at the 106, 107, is that like Maryland's cost? Like the dollar amount of the per capita spending compared to the United States? Where is Maryland in terms of how the actual per capita amount compares to the per capita for the United States? In other words, these are chart we're looking at on slide 5 was the rate of growth in per capita spending, and it's similar for Maryland and the US. But is Maryland's per capita spending starting from a higher or lower than the national average?
Higher, it's higher, because Maryland is 7th. There are 18 states that have a per capita result that is higher than the nation, and in 49 states, and Maryland is 7th. In that,
So the 106 in 2020 we're 6% higher.
6%
Okay, I'm
higher.
sorry, that's what I was trying to
That is a
get
per
at.
capita.
I was trying to get it inartfully, so I can look at that 107%, 106%, and that will tell me where we stand. in
Yes,
terms of
yes,
dollars.
yeah.
Okay.
Okay, so all right, the ratio of per capita health care to per capita income shown on this slide represents the share of personal income devoted to healthcare and is one indicator of individual purchasing power for healthcare needs. In 2020, Maryland residents spend an average of 16.2% of their personal income on healthcare compared to 17.1% spent nationally. Both per capita spending and per capita income were higher in Maryland than the nation. Actually, the results I'm not showing here, but for Maryland, when you're looking at the per capita spending, it was at 10,839 for Maryland versus 10,191 for the nation. When you look at per capita income, Maryland was standing at 66,797, while the nation is standing at 9,510. But the gap in personal income is larger. In 2020, personal income per capita was about 12.2% higher, and healthcare per capita spending was about 6.2% higher in Maryland than in the nation. Therefore, we can deduce that the share of income quoted for healthcare spending in Maryland was lower than the nation. Comparing the ratios of spending to income ratios for Maryland and the nation over time, we see that the relationship here is quite stable. Next slide, please. This slide that shows the total healthcare spending as a percentage of personal income does not show any new information from the previous slide, as the calculations here are equivalent. If you're looking at the ratio of per capita spending to per capita income, doing that division, it's the same as just having the raw spending over the raw personal income. So we could see the same result that Maryland is constantly lower than the nation throughout this time period from 2017 to 2020. Same result as we saw on the previous slides. I'm not going to talk about this slide too much. Next slide, please. So how were Maryland $69.5 billion in healthcare spent? Looking at it from a source payer perspective. See that spending reimbursed by private health insurers or paid out by individuals made up about the 28% of the personal healthcare spending in 2020. The other third-party payers and programs, the next largest category, at about 21%, followed by Medicare at 20%. Medicaid comes in at 17%, followed by the military, which includes Defense and Veteran Affairs at about 8.3%. That's followed by the government public health activities, which is COVID-19 at 5.6%, and the uninsured, which is less than 1%. So these are the distribution of $69.5 billion when you look at it from a payer perspective.
Kenneth, on this, your other third-party payers is kind of bigger than I think most of us would have expected. Do you think that's again a COVID-19, but sort of a catch-all for, what it costs the governor to have the National Guard give everybody a vaccination at the parking lot?
It is such a large category, and when you look at the maternity child health, that is a pretty large category. If I'm looking at just for private insurance, if you look at in 2020, there were about 68,586 live births in Maryland from the vital statistics. Just walking through a rough calculation that I did. About 34% of those births came from Medicaid. So therefore 66% of all those births were actually covered by private insurance. So that leaves about 45,000. About 33 and 34% of all live births are C-sections, right? So that will be about 15,246. Now the average cost for a C-section using the weighted cost data trending at about 2.2% using data from our private insurance report, trended forward to 2020. That cost come about 16,903, for the C-section. Normal birth comes in about 13,754. When you add those up, it comes to about $670 million for 2020. And that is just for the private insured. So you can imagine, for all of those births from Medicaid as well, that will even have a.
But I'm asking about on chart, sorry,
20.9.
the 20.9 that is just called other third-party payer.
That's what I'm saying, that I'm picking out.
But when you ran through the details on the burst, they're gonna be over in privately insured, Medicaid. They're disabled, I guess, maybe a little Medicare, but why would they appear in some sort of a, because this appears to be kind of a catch-all. And I can see why, especially in 2020, you might need something like that. I'm not sure how that, unless you're telling me that's charity care, but that's a tremendous percentage for it being charity care.
And
That would be then an uninsured, right?
you have
But yeah, probably. Yeah.
we have the substance abuse, mental health service association, which comes in at about another 780 million in spending, and
So maybe if we can, I don't think we're gonna get too far in this, but we can provide some further breakdowns on, I mean,
On what's in there.
on what's in 20.9.
Yeah, and I don't think, I mean, it's unusual, but I mean, it was 2020, which was a pretty unusual year, so.
but
But still, that's like $11-12 million.
But then, that's, more than whoever, more than Medicaid, more than Medicare, that's big.
Where do self-insured plans fit on this pie chart? Are they included here? Because they aren't in the MCDB.
self-insured plans, they are in the private data, right? That 20
Privately insured,
private insured.
certainly a logic there.
Yeah, I guess the question was, would you have the data on them if they're not submitting to the claims database? Do
No,
we-
this is, remember, we are getting this from the National Health Expenditure Report. So they will have all the information.
Got it. Okay, thank you.
And just a clarify, Gary, this is based on Maryland residents, not Maryland institutions. So it's like use an example like Hopkins. All of Hopkins revenue is not added in here because a portion of it is for services delivered to residents outside the state.
Right, that's correct. That is correct. This is for Maryland residents only.
The residence based thing.
Resident-based.
The 21%. Is it possible it's picking up FEHBP?
I think.
A lot of feds in Maryland. Okay. It would just be good to nail that down before it goes public.
All right, next slide, please. So looking at the $69.5 million from the type of service perspective, see that the single large share of personal healthcare expenditures were actually attributable to hospital care, including both inpatient and outpatient services, accounting for about 34% of the total spending. Physicians and clinics made up the next largest category of over 1/4 of the total spending, comes in about 26%. Prescription drugs and other non-durable medical products make up about 10%, followed by about 9% for long-term care, which here I lump together nursing home and home health. The dental services and other health residents and personal care accounted for 9% and 6.4% respectively. Other professional services and DME accounted for 6.1%. COVID-19 came in at 5.6%.
One question, you have pharmacy at 8.5% on here.
Yeah, but I'm including the non-durable. Non-durable products.
That brings it up to 10. I guess my question was, if, at least in the commercial market, what we're considering pharmacy, the total cost is pushing 1/3 of the total dollar. And I'm wondering if there's a big difference between what my understanding of what the pharmacy bill is and 10%. I'm wondering if there are a lot of the most expensive drugs actually come in as medical charges because they're, cancer therapy is administered under a medical, doctor's office, submitted on a medical claim rather than, going to a.
Some of
PBM.
them bundle.
Randy,
Like an
thank,
oncology.
Randy, thank you for bringing that. I was going to ask exactly same question. What is this physician and clinical services? 26% is quite high. Is that include diagnostics also? And as you said, the drugs which are given in physician's office, like oncology, rheumatology, and some of the gastroenterology, these are very expensive drugs. I think that may be part of that because your prescription 8.5%, you're absolutely right. That number looks very small.
But in this prescription drugs are retail,
Yeah.
according to the, these are retail.
Okay, so they would not include this. So hospital care and physician and clinical services may include on-site drug.
It seems to warrant at least a footnote.
Worthwhile.
Because that 8.5%, I was thinking the same thing, is significantly lower than what I have seen. So that explanation would be important.
Oh, yes, retail.
And what is our source for drug data? Is that PBM data or something?
This is from.
Ed's trying to, estimate?
This is from the CMS actuaries, the National Health Expenditure.
our friends, the X-rays. Wondering how well they would, I'm wondering if their access is on things like PBM data. If, it's going through a private, it's going through a Medicare Advantage plan, and it's a PBM, are they gonna
But they don't
know?
have,
They don't have the right to ask for it, I don't think.
so. Since it's
Yeah,
retail.
the data sources, one of the things, important, a couple points here. One is we stopped this for, it says 7, I'd say 10, but that's a long time, and the data sources disappeared in some cases, or so we started out this year really using what's called the CMS State Health Expenditure Reports that they do
Okay.
for each state. And then they were done up through 2019. And then we augmented that with our own data collection methods, which were not that different from what we used in the past, which was, it'd be great to say the PCD can supplement directly. We just add it up, but it never works that way. And you add, it's kind of like making a sauce. A little, we're using the federal methodologies up through 2019 and then applying our own adjustments to 2020. That's what we would propose to do probably going forward. Because this endeavor, the reason we stopped it just became so expensive. And people would always say, Medicaid, you have Medicaid at $18 billion. We actually think it's 17.5. And, so we wanted to get a top line number because oftentimes that's the number that people ask, how much is the healthcare economy in Maryland? And back when we stopped it, it was 55 billion. And now we know that it's grown by 15 billion over the course of that time period. I don't think I would argue for going back and doing this accounting or a framework, but we try to piece together the best information we can get. And it's been great to hear people, poking some holes in it because we don't have the perfect source, but the obvious glitches and anomalies, and peculiarities, you're helping us flag. This is the first time we've rolled this out. So it's helpful to know. And we're going to, when we make it available to others, we're going to caveat it that this is the first attempt. We're going to get better at this, but we didn't invest.
You will go out on the public record, so you at least want to catch a few things. And as you say, if you're restarting, it used to be that like with the actuaries data, it's claims data. it used to be fine when Medicare Advantage was 10% of the program or 15. It's now 50% of the program. And so unless you're gonna kind of double everything, it is in that footnote. Are they basing it on claims? Have they done any kind of projection forward to take into account Medicare Advantage? Or are you basically only seeing half the Medicare population?
So here's what CMS says about the prescription drugs.
Yeah.
Is that it covers retail sales of human use dosage form drugs, biological drugs, and diagnostic products that are available only by a prescription.
That's retail pharmacy.
Yeah.
So a retail pharmacy, they're
Which
getting,
includes
it sounds like
specialty.
they're getting. So I wonder if they get mail order in that or anything.
I would think they would get mail order, or they would count mail order, or say they.
Or they would have footnoted it. I mean, they know what they're doing. They wouldn't have just flown it off. They're not,
It may be worth noting in the final report, though, that the numbers for physicians and hospitals would include some drugs, medically administered drugs.
Right, good. So next slide, please. So what we have learned from this reporting so far is that in 2020, Maryland spent an estimated $69.5 billion on personal healthcare. And that the growth of total personal healthcare expenditures between 2019 and 2020 rose faster than the nation. And that on a per capita basis, Maryland healthcare spending was mostly below or at the national per capita, except for 2020, where Maryland's per capita trended slightly above the national per capita result. Lastly, although Maryland earned more, but it spent a lower proportion of their income on healthcare. 2020 residents spend on average of 16.2% of their personal income on healthcare compared to 17.1% spent internationally. So that ends my first swing.
We recognize that, this was a, a first attempt, and, we're gonna, as we get the answers back to you. I mean, I think the top line number, we wanted to have some confidence in, but recognize that people are gonna punch some holes in this as we drill down further. I think the most important, walkway point is that, some of the hospitals will say, well, whereas we're reporting hospitals have this amount generated, $20 billion ourselves, where are the non-hospital, where are the non-Maryland hospitals revenue? Because we accounted for all you're showing for hospitals. And the answer is that you factor out non-residents who use Maryland hospitals. I do. To start.
It's not.
Yes, thank you. I appreciate that. You have a 4-year time span, which means you could go to 5 next year. And that I feel, at least looking at these, a 5-year picture is much more informative than a 3-year, because there's so many things you go, oh,
Absolutely.
3 years. Oh, it's a trend, and it's not really.
So we want to have,
With COVID.
Yeah,
so
exactly.
you want to have 5 years. We want to have sufficient data before the pandemic, and sufficient data after the pandemic, so that we can,
Move it on. Yeah.
Thank you. Are there any questions or comments? We'll let Ken go.
Nice.
Thank you. On to agenda item number 5, overview of work assigned in 2023 by the legislature. Tracy DeShields, Director of Policy Development and External Affairs, will provide us with an update on the status of the 2023 legislative interim initiatives and studies that we have been tasked to do. Tracy, you have the floor.
Great, thank you. Good afternoon. As the chair just mentioned, I'm just going to give you a brief update on the various legislative projects that we're working on from the 2023 legislative session. Next slide, please. Great. So first, we have a couple of things related to trauma funding that we're doing, and I'll just talk about the Commission to Study Trauma Center funding first. So where we are with that is we currently have a list of appointees. We just have to officially notify them. and then to schedule our first meeting for the commission. And the charge of that commission is to look at the statutory formula for trauma funding. So it's going to be broad. They're going to be looking at that formula and then making recommendations around that. And we are hoping to have a first meeting sometime in August, if that's possible. The second has to do, this was budget language, and we were required to submit a report on the criteria for distributing 9.5 million to trauma facilities. And then 45 days, we have to, coming up with that, we have to send a letter to the legislature telling them what that criteria would be. So we've recently reached out to the CEOs again, asking for names of representatives that can be involved in 2 to 3 meetings, trying to discuss how these funds should be distributed among the trauma centers, or however they decide to come up with it. So we've sent out a letter. We're just waiting for responses back. And we also suggested that the same representatives on the commission can also be representatives to this particular group to meet. So one is the 9.5 is clearly separate from work of the commission to look at the trauma funding formula. Any questions? Next slide, please. So in the area of behavioral health, I'm going to skip House Bill 1148 and Senate Bill 582 because that comes up again in my slides later. Initially, first, Senate Bill 283, House Bill 418, the Mental Health Workforce Development Fund established. So we are in the throes of planning activities. One of the main stakeholders championing this particular legislation we're working with, the Mental Health Association. So we're in the process of developing a work plan. We've identified groups or organizations, stakeholders for a work group that we would establish to help provide input and feedback into our workforce development plan. And we're in the process of drafting an RFP to be released late summer, early fall. So we're talking maybe the middle of August to beginning of September for that. And then Senate Bill 154, which deals with public health, mental health advanced directives, awareness, and statewide database. Again, staff, we're working with the department, MDH, to develop a strategy for the department to implement a public awareness campaign and to develop an approach to enable behavioral health crisis providers to access advanced directives accessible through CRISP. So that's going well. We've had several meetings with the department. We've also engaged the Mental Health Association, who is very interested in this area. In fact, on their website, they do have information about mental health advanced directives. So, and we think that's moving forward pretty steadily. I believe we have another meeting coming up in the next couple of weeks.
Hey, Tracy, Commissioner Brzezinski here. Can I ask you a quick question?
Sure.
Is there a separate mental health advanced directive from a typical advanced directive? Is that what we're talking about? Or are we talking about mental health
Yes.
providers? Oh, really?
Yes. So, okay, so one of the things that MHCC, well, we really did not have a clear understanding about how a mental health or behavioral health advanced directive would work. And so MDH, through their Assistant Attorney General, they were able to kind of give us a little more explanation. So it's more really about treatment, care, like treatment, like certain types of treatment or instructions around treatment or how to address something more than if you're thinking about an advanced directive, if you're sort of into life or late stages of something. I think that's how we sort of think about it. And from their point of view, it's different. It's let's say a person can say, if you find me wandering in the street and I'm not sure where I am, that sort of thing, then there would be
Okay.
instructions on who they would contact, what medications they may be on.
So
that
this is for someone who has a mental health illness that impairs judgment and cognition. This would be something they'd fill out while they were competent and clear-headed and say, when I'm off my medicines and I'm suffering a mental
Right.
health crisis, I'm not competent for medical decision-making. I want you to do this for me when I'm, when my schizophrenia is out of control and I'm hallucinating. So do these things, contact these people and
Yes,
so forth. So it's basically a direct, this is the first time I've ever heard. It's very interesting. So it's
Yeah.
a directive of what kind of care do I want when I am not competent due to my mental health condition.
right. And one of the things that we have talked about and learned is that you can connect the two, sort of the traditional thought about advanced directives as well as this behavioral health advanced directive. So you can kind of bring them together, but really the focus is on the latter part, like you said, about treatment, what to do, how to address what's going on with me, that sort of thing.
That sounds like that might be fairly effective at trying to reduce some of the hospital and emergency department burden of the mental health crises we often see there. So,
I
okay,
think so.
thank you. Yeah,
And-
very good. Thank you.
Oh, you're welcome. So, next slide, please. So, protected health information. So we did have legislation that passed. David and Caitlin are gonna talk about that in detail with you and bring you up to speed. So I'm not gonna do that here. Next slide, please. Okay, dental health services, House Bill 1146. This bill required the department and MHCC in consultation with the Maryland Hospital Association to submit a report that details sort of the results of a survey and regional needs assessment, as well as regional plans. So this work has really been split up. And the department taking the lead here. We have completed the survey that we're required to do, dealing with ambulatory surgical centers. That information has been relayed over to the department. The Maryland Hospital Association was also to do a survey, which they've completed for the hospitals, and that information has been forwarded over to the department. The department right now is looking to do the needs assessment study. They are working through right now plans for that is with the Institutional Review Board for approval. And so they'll move forward and then come up with the needs assessment and then figure out any kind of regional plan to come up with to report back to the legislature. Next slide, please. So we do have a number of mandate studies that we're required to do. The first dealing with the treatment of alopecia. We did a bid board proposal that was released on July 12th, and proposals are due next week, July 26th. So we're waiting for that.
But if the bill failed, why are we doing this?
Because that's actually when the bill fails, that's when MHCC's role comes into play and the legislature can ask if we can.
Oh, I see. So as a, you know, I'd like to bring this up next time, and I think if we had better information, maybe it would do better.
It's a punt.
Yes.
Come on, sure. Like having a commission.
Yeah, yeah.
That provides a way out to, if we bring it forward again, we're gonna have better information. So it's
Yeah.
both a warning and a signal. So these when they come to us, they're a signal that they're gonna be reintroduced.
Okay, okay. I mean, that doesn't seem crazy to me. I don't believe you have lobbyist information. I'd like a neutral third party to take a look at it. Okay.
Or I just don't want to decide.
I don't want to decide right now, and my term's up, and let's punt. Okay.
So, and then Senate Bill 108 deals with annual behavioral health wellness visits. So this again was posted to the bid board. It was released July 12th. And proposals or responses are due July 28th. And then with regard to Senate Bill 184, House Bill 376, diagnostic and supplemental exams, biopsies for breast cancer, cost sharing. That RFP or bid board proposal actually is with our procurement officer now for review and should be released shortly. And
Now, in terms of this kind of stuff, for the last two that you just talked about, do we assume actuarial firms will be bidding those? And they'll pay this per member per month on kind of if you waive every cost sharing that's out there, this is what'll happen. Okay.
We gear them towards actuarial.
Yeah, yeah.
There are some
That's right.
pitfalls though in defining the benefit where the actuarial firms are gonna be best at calculating the effect of a particular set benefit, but sometimes the question is not so clear on exactly what the scope of their benefit would be and who would be providing service.
Right.
There's some nuance.
next slide, please. Thank you. All right, so these are additional mandate studies, House Bill 1217, Senate Bill 805, Maryland Medical Assistance Program and Health Insurance required coverage for biomarker testing. So this bill actually did pass. The legislature wants MHCC to come back with a report looking at the impact of passing this particular legislation. So, and the report is due December 1st, 2025. The RFP for this has been drafted. And again, it is in review with our procurement officer at this time. The next bill, House Bill 937. This is a bill that passed in 2022. Abortion Access Act. And a question that came up was around the costs for delivery and labor and delivery. And sort of like, I guess, cost sharing. Again, this is another one where this has not really been posted yet. However, our draft RFP has been completed and it is now with our procurement officer. So the idea here is for some of this, we're not trying to release them all at the same time. And then lastly, MHCC is required to do a 4-year mandate study. And that's looking at the impact of mandates, how we compare to surrounding states such as Pennsylvania, Virginia, Delaware, et cetera. And this has been posted. We have received proposals and they are currently under review. So, next slide, please. So this bill, Senate Bill 509, House Bill 702, nursing homes, acquisitions and licensure. This bill passed during this past legislative session. However, there have been a hurdle, if you will, we're concerned addressed by a health information exchange vendor was brought to our attention concerns about Maryland law and possible conflicts with the Cures Act exceptions on information blocking.
We're
Yes.
actually one slide behind, right? On nursing homes.
You were talking about the next slide, aren't you?
No, this is the right slide.
But this is not health information.
This is acquisition.
This is different. This is different. Oh, wait, I am.
Yeah, it's coming up.
Thank you, thank you,
coming up.
thank you. This is my total, okay,
Commissioner, go
breakdown.
ahead.
But I know, it's too great. Okay. So forget it. Forget, scratch what I just said.
Marcia's
So,
issue,
yes,
right?
so nursing home acquisitions and licensure. That's it. Not registering the bill title. Okay, so.
Just testing us, be sure we're reading. Yeah, right.
So on this one, we've done a lot of work, or staff has done a lot of work here. We had a first meeting of the work group on, related to this particular bill. That requires us to do a study and make recommendations regarding, nursing home acquisitions. Marcia attended the first meeting. So we developed a work plan, a meeting schedule, and like I said, the first meeting was last Thursday, and I believe we have another one coming up in the next week, 2 weeks. Yeah. Yes, it was a good meeting. It was sort of an introductory meeting around the issues. Second meeting coming up, we'll talk more about private equity, the impact with regard to nursing home sales.
Your comments have been heard.
Yes.
Of course, you put me on the committee.
What happens if you demonstrate it?
We sat through a lot of meetings, your return on investment.
Okay. Okay, so next slide, please. Yes, now we're electronic health records information exchange, Senate Bill 648. Basically, this bill has to do with release of information from nursing homes over to CRISP. They're required to do that. Also, it makes things consistent with House Bill 1022, which passed in 2021, where nursing homes were required to provide information to CRISP around healthcare. So, and part of this is the information that a little bit that David and Caitlin will talk about. They're not talking about the full regs, but there is full regs that are being drafted related to electronic health information, and this would sort of be wrapped up into that. Questions? Next slide, please. Okay, telehealth, Senate Bill 534, House Bill 1148, Senate Bill 582. Preserve Telehealth Access Act of 2023 is sort of like part 2 for what we did with the telehealth report that came out last year that you all did, and that was general related to telehealth generally across healthcare and access to that and how it's going to be paid. This particular study, both in 1148, Senate Bill 34, deals specifically with behavioral health services, how it's utilized, what the cost is, payment, and also in particular looking at audio visual and audio only telehealth technologies and how it's being utilized in behavioral health. So currently right now, study design planning activities are underway, and that staff plans to release 1 or possibly 2 RFPs in late summer or early fall. So we're looking at late August or September.
Excuse me, I did have a question on telehealth. For the study being done, is there any Is anyone looking at people, for instance, with rare diseases who may have to get care outside of Maryland because there really isn't treatment in Maryland or very little, and then follow up and would telehealth be reversed?
So it sounds like that would be covered in the interstate telehealth study that we're working on. That's good. We're going to present to you later this fall. That was not the specific rare diseases, but how do we make appropriately trained and credentialed physicians licensed in other states available to provide services in the state of Maryland. I don't think it's specifically looked at rare and uncommon conditions, but it did. I think the scope of that will appropriately address that population as well.
I certainly knew when I was working with a lot of people who, had to go outside of state, and Maryland, not as much Maryland, but other states as well, where the only treatment they could get was outside of the state.
We're trying to streamline that. There are some questions about the equivalency of certificate of licensure requirements that has historically been a major concern for providers here in the state who contend, you don't want providers licensed in kind of loosely states with loose license requirements, parachuting into the state of Maryland when they may not be even close to the standards that we impose on providers here. I think we've reached a compromise that addresses generally everyone's interest, not perfectly, but I think people are walking away satisfied. David will talk more about that in a couple of September.
This is quite an agenda. Do you have enough? Did they give you the budget for this?
We have the budget. We are relying on some consultants,
Yeah.
but the strategy in the future will be to try to intercept some of these before they get into statute, because some of them are nice to have, but the legislature doesn't necessarily need to have them. Some of the mandate studies, I think, fall in that area. That with the ACA, it's very hard sometimes to put in new mandates. Now, some of the quote unquote mandate studies are not really mandates at all. They're shifting co-pays or payments between patients, the payer. So they wouldn't really fall under the essential health benefit limitations that existed in the ACA. But there's been a surge in mandate for insurance coverage issues and expansions of insurance coverage over the last 2 years after about a 6-year dormancy, if you will, because everyone thought the Obama administration wouldn't allow it. They did nothing. The Trump administration would not allow it, and they did nothing. And likewise for the Biden administration, that people are becoming more tempted to put in additional coverage mandates that go beyond what was defined in essential health benefits.
Gotcha. Yeah, it's just a shame that there's no way for the appropriators to take this into account when all of a sudden you get, a laundry list like this.
See, staff changes adversely impacting our ability to get this done. I mean, they must be in some degree, but in a degree that we need to deal with.
Well, I mean, we are recruiting as aggressively as we can. But it's a competitive labor market. That's all I can say. We can do this, but here's a challenge. This year is particularly a challenge. I've met with the chair of HGO to point out that we can't pick priority items. It can't just be a catch-all. There's also I think the department is even more of a pickle than MHCC is, in that the legislature being very proactive and wanting to do more is reaching out and becoming increasingly like an executive or grabbing executive branch resources that they've already assigned duties to formally through statute and assigning them special duties that are important to the legislature. And it's going to be more than just MHCC complaining about this. The era of good feeling when the House, Senate, Governor's office are all of the same party does create some challenges sometimes because everyone's from the standpoint of the administration and the big departments, they're supporting both the governor and oftentimes now the legislature as well. And
The legislature's never considered, kind of the equivalent of the Congressional Research Service, or California has the Office of the Legislative Analyst. They have their own research staff.
They have their own research staff, but they're typically pretty busy too. It's called Department of Legislative Services, which is the equivalent of CRS.
Okay, outside of the budget issue though. I mean, it's good for the MHCC to play a role here.
Sure.
We do represent a number of constituents within the healthcare system and should be able to present something that just
It's beyond, yeah. As long as they,
I do think the
as long as
resources.
then doesn't get squeezed on budget.
Next slide.
Oh, sorry.
You're fine.
It wants us to look at Mount Fuji.
Oh, nice.
Yes, I do.
Isn't that lovely?
Yeah.
I think you should consider- I mean, it's lovely and symmetrical, but perhaps the image of K2 or Krakatoa.
This is right from the bullet train. You just take this shot.
No, I was just gonna point out that yet again, you, I think, get the award for the best last slide.
It's just going to spur people on.
Yeah, Steph, hurry to do.
I usually.
Does conclude my formal presentation.
Okay.
I do.
The last slide of the day.
I think she had something more to say.
Right, sure, yeah,
Okay.
you're right.
Thank you very much.
Thank you. But I do have a last word for you to think about.
Okay, we're
Okay.
appropriate for 340.
Yes. All right. Is it better to be a big fish in a small pond, or small fish in a big pond?
Thank you. Yes, the answer is yes. Item 6, update on the Maryland Patient Safety Center. Included in your packet this month is the fiscal year 2023 annual update from the Maryland Patient Safety Center. As a reminder, Maryland state law authorizes MHCC to designate an organization to serve as the Patient Safety Center for the state to develop, coordinate, and implement patient safety initiatives across the state. The current designation ends in 2025. As part of the designation process, the MPSC is required to update the commission every 6 months on their activities and accomplishments to ensure compliance with our designation agreement. Dr. Blair Ike, President and CEO of the Maryland Patient Safety Center, will provide a brief update on their programs and activities. Before I yield the floor, I do want to note that Dr. Ike retired last month after spending the last 3 years revitalizing the MPSC. He leaves the MPSC in a far better position than he found it. Thank you for your efforts and thank you for coming back temporarily from retirement to report to us.
Well, thank you. And hello to all of my commissioner friends and the staff friends. It's great to see you again. All of those who were patiently awaiting my retirement, I apologize. I actually have not retired yet, even though July 1st was supposed to be it. But for news on that, how the search is going, and hopefully we will find someone to replace me within the next month and a half, you can speak to Commissioner Boyle, who is on the search committee. And privately, she can give you some updates on that. But what we're hoping is that over the next about 6 weeks, we've got some excellent candidates and we'll get to somebody so I can happily go off into retirement. But
The
I
search
will.
is going well.
The search is going. Thanks, Marcia. I will miss, every interaction I've had with the Healthcare Commission, including all the things Ben has made me do over the last 20 years. It's as much. This has been as much fun as when Mark Jensen and I were on the MHA Executive Committee together. He can tell you about that. But we are doing great. I mean, we are doing great things. And if we go to the next slide, and I'll try to be brief, but you know me, I talk a lot. The mission is still the same. It's keeping Maryland healthcare safe. Our submission that we don't tell everybody, but I'll tell you, among the 5 of us who, the small staff at the Maryland Patient Safety Center, is get stuff done. We really feel that's important because the state needs us to move things forward with patient safety. So you see the vision and the goals, which haven't changed significantly since we created them with the board about 3 years ago. We do review them every year. So we go to the next slide. We talk about a lot of the activities. Some of these you've seen before. We do a lot of safety education, and we've got slides on these to follow. Our patient safety conferences, our patient safety officer forums across the state, Caring for the Caregiver, which is our support for health caregivers in times of stress. Our Mid-Atlantic Patient Safety Organization that reports and discusses errors with patient safety leaders across the state. We administer the state's maternal mortality review program. We have the Minogue Awards for Patient Safety, which are a great event every year. We do major collaboratives. I'll talk about a few of those, including birth equity and our maternal safety programs, and the workplace violence. And I'll mention that I think I mentioned 6 months ago that the Healthcare Commission and the Maryland Patient Safety Center worked together on Senate Bill 700 from 2022 to create a plan. We had a work group to create a plan for a public awareness campaign for the violence in the healthcare workplace, which is 3/4 of the workplace violence that is reported to OSHA every year now. So it is a major issue for all of us in healthcare. We submitted that plan to the legislature. Unfortunately, did not get the funding. We were looking for $2 million of funding. Did not get that this past year, but we're at it again. The commission and the Patient Safety Center will work with the governor's staff and legislature to get that funding so that hopefully we'll all see that public awareness campaign in 2024. Next slide, please.
What, can I ask you a question?
Yes.
Why we need this public health awareness? What is the implication if a patient comes and beat a nurse or doctor in the emergency room? What happens to them?
There's a couple of reasons why it's very important. But one thing I will say is in most jurisdictions, including Maryland, a patient, if you're a patient or family member who attacks attacks a healthcare worker is a misdemeanor. You attack a police officer, it is a felony. And they know this. So that's number one, just to talk about what you asked. But we're losing staff. I mean, this is incredible stress on our staff. And if they're injured, even if they want to come back to work, we don't have them for a while. It's just not the right thing to have. And we
there is
need
a problem. Misdemeanor is a problem. It should be felony. It should be like attack on a police officer. Legislators needs to work on that rather than campaign money.
Well, we believe that we and the commission and others feel that a public awareness campaign is the best step right now to have the public aware. Hopefully it'll stop some of that violence, but it'll also raise the awareness to the legislature and everyone else. So hopefully more on that coming. Our education examples, we've been able to expand our education efforts, both online and in person. Now that the pandemic is wound down, we've been able to do a lot more. You can see many of them there. I'll just point out with our new staff member from last September, Dr. Adrian Burgess, who's an RN PhD and a national expert in maternity care. We've been able to add a lot of maternity, in this case, perinatal and neonatal safety programs, including our webinar series. We did the perinatal safety in the spring, and we'll be doing the neonatal this fall. We coach for patient safety. We do a lot of, again, quality training like FMEA and root cause analysis. But we really are starting to get more into what I would call the boot camp for patient safety training in terms of more training in team steps, more training in the pitch to leadership about why quality improvement and patient safety are important and should be funded. And e-learning modules such as data visualization, so that you can take the studies that you're doing in patient safety on your unit and you can represent them so that others, including leadership, can see. I want to point out we won an award from AHRQ this year on a Team Steps video we did for our birth equity program, and that'll be distributed nationally very soon. The next slide. These were our two this was our conference this spring, which was on health equity and patient safety, covered a vast amount for the 1,000 who healthcare staff who attended it this year, 500 online, 500 at the Hilton in Baltimore. And then this fall, this is the upcoming medication safety conference we do every fall, optimizing technology to improve medication safety. We've all heard of events associated with electronic medical records and other technology that hasn't necessarily improved patient safety the way we had hoped it would. And so we're going to discuss that and see what we can do in the state of Maryland to make technology safer and have it help us to improve patient safety. Next slide. This is our Caring for the Caregiver program, which is started as the RISE program at Johns Hopkins. We do this in partnership with the Armstrong Institute for Patient Safety and Quality at Hopkins. We are now in half the states in the country, and you can color Indiana blue now as, oh no, I'm sorry, the gold is, I get that backwards sometimes. The gold is where we are. Indiana is gold because the Indiana Hospital Association has decided to train all of their hospitals in caring for the caregiver. Again, that is peer support for staff that are in times of stress. And they've been in stress a lot since the pandemic and the workplace violence. So our biggest news on that is we've worked with Seaman Healthineers, which is Siemens online education, healthcare education platform, which is the largest in the world. And we have a module for caring for the caregiver coming out, we hope in August, that will be international. It'll start in the United States first, but cover all of Europe and hopefully all of the world very soon. We want to spread this. We want to spread this program as best we can. Next slide. This is one of our bigger programs. I've talked about birth equity before. This is training staff, especially non-maternity staff. There is another program sponsored by a federal grant called the MD Mom program. Johns Hopkins is running that. We participate in that. That trains maternity staff in recognizing complications of pregnancy, what to do about it, and specifically the disparities that are seen in the outcomes of patient safety. Again, Black women have twice the rate of maternal complications during pregnancy and 3 to 4 times the rate of maternal mortality. You hear that in the news all the time now. That's national, that's not just in Maryland, but it is a very big issue for us too. We have spread the birth equity program in ERs around the state. By the end of this fiscal year, we will have been to half of the ERs in the state, many primary care offices, and we're trying to get into the federally qualified health centers also. So more on this as we spread it out, but this is also under the leadership of Adrian Burgess, who again, as I mentioned, just joined us this year, but has really been expanding our program significantly. Next slide. Another program Adrian is leading is Count the Kicks. This started in Iowa. Actually, it started in Scandinavia and brought over to Iowa. And it is a very simple concept that if we can train expectant mothers in the 3rd trimester to be more aware of movements of the baby, we can prevent a number of stillbirths. Because when they are alerted, Count the Kicks, to a reduction in movement of the baby, they are to get help quickly, right away. And that can be the difference between a stillbirth and a live baby. And so this is catching on very quickly. We're already at half the hospitals and half the health departments in the state, and we'll move that to hopefully all of the hospitals, all the health departments, so that we can distribute this material and get it as a statewide initiative very soon. You'll hear more on that again at the next update. Next slide, please. Just quickly, how we choose the program. It is a collaborative process, especially by our wonderful board of directors. As you know, Marcia is the representative of the commissioners on our board. We have 2 Maryland legislatures, Speaker Pro Tem Sample Hughes and Senator Malcolm Augustine. But we have representation across the field, and as of our next board meeting, when we have 2 more candidates that will be considered, more even increased representation of the community, which we feel is very important. We also work a lot with healthcare organizations, of course, the state, federal agencies, and many more, because it has to be that big village to create the programs. What's most important for us to work on? Can't work on everything. We've had to focus, but I think we focused well on what is needed by the state. So next slide. So these are some of the newer and expanded programs for the coming fiscal year. We'll expand the birth equity, as I said, to get to 50% of the hospitals by the end of fiscal year 24, and hopefully to all of them over the following year, year and a half. We have received a grant from the state to have a maternal mortality summit, which we think will be important in organizing efforts which need to be organized across the state on the efforts to reduce maternal mortality in the state of Maryland. The Count the Kicks program, as I just described. Dr. Burgess has started a perinatal safety fellowship program and has recruited 10 nurses and doctors across the state who she will mentor in safety projects that then can be presented, we hope, at one of our annual conferences, so that they can take that knowledge and improve the safety programs at their institutions. We are starting to work more with MIMS on several issues. As you heard before, a major issue in the state now is emergency department wait times. We're working at the front end with MIMS on department throughput in getting their rigs in and out faster from the ERs, which is one piece of the problem. We also are exploring how can we help in assisted living. It's not easy to get data across the state on assisted living, especially in the smaller facilities, but we're working with MIMS on at least trying to figure out how much trauma is occurring. That's mostly from falls. It could be from other sources, so that we can get involved there, at least to survey that, and then maybe create a collaborative to try to reduce it. And then we are doing the same birth equity training we're doing in ERs with the MIMS personnel, the EMS personnel. We're also developing more caring for the caregiver modules for, again, staff in times of stress, having to do with equity issues and also violence in the healthcare workplace. And we are getting better and better at live streaming all of our conferences so that we can do both the presentations live for those that want to attend and share over lunch, and those who can't. We always consider ourselves a small state, but at the extremes of the Eastern Shore and Western Maryland, it's a lot easier to just get online to see a conference. So we're trying to do that. And we'd be happy to share our learnings with some of our surrounding states if they want to join in too. So we'll continue to develop our ability to both live stream and have in-person conferences. Next slide. This is just a reminder that working with the Healthcare Commission and our representatives in the legislature, we were able to get an annual $1 million of funding that help us do all of this work, and that by our agreement with the Healthcare Commission, that we report to you both how we spent the money for that last fiscal year and how we're going to spend the money, which I've already submitted for the coming fiscal year. So for the last fiscal year, we have the results through May, not quite the way through June. We'll get you those at some point soon. But if you go to the final slide, through May, this is one more slide.
Next slide.
Next slide, please. Yeah, there we go. You can see through May 31st, 875,000 of the 1 million. So through the end of June, we might have spent it all. I'm not sure about that yet. But again, it is gone. That funding has been so needed and so well spent, we believe, because a lot of it has gone to the birth equity program, to our safety conferences, and for other safety related issues. Some has gone to administration, especially for our, helping us bring on Dr. Burgess as our to expand our programs. So thank you to the Healthcare Commission, certainly thank you to the legislature for the funding. It is being well spent. It will continue to be so. Don't know that we won't be coming back in a few years for more to spend it wisely too. But right now it is greatly appreciated. So I'll be happy to take any questions, but it's been an honor to work with you all over the many, many years when I was at Holy Cross and now at the Patient Safety Center. And I look forward to checking in every once in a while. I'm sure the questions will come my way every once in a while about what happened when, and I'll be happy to help out in an advisory capacity in the future. Thanks.
Thank you, Dr. Ike. That was a robust presentation. Are there any questions or comments?
Just thank you for all your work.
Yeah.
Thanks.
Gonna miss you.
And I'll miss you all. Thanks.
Great. Well, thank you. With that, we'll move on to agenda item number 7, which is an update on regulations to implement HB 812. House Bill 812 requires MHCC to adopt emergency regulations to restrict data sharing of patients who have obtained legally protected health care within 9 months of the June 1, 2023 effective date. The law establishes requirements for health information exchange organizations and electronic health networks on the disclosure of legally protected health data, including reproductive health services related to the provision of abortion care and other sensitive health services as determined by the Secretary of Health. David Sharp, Director in the Center for Health Information Technology and Innovative Care Delivery, and Caitlin Heff, Assistant Attorney General, will provide an overview of our work to develop the emergency regulations and some of the challenges voiced by the EHR and HIE industries. David and Caitlin, please proceed.
Okay, thank you, Chairman. Good afternoon, Commissioners. So as noted, we are co-presenting today, so we'll go through a couple slides independently and then happy to answer questions along the way. So as the Commissioner, the Chairman noted, the law establishes certain requirements for health information exchange entities, or HIEs, regulated by COMAR 102518, and electronic health networks, or EHNs, that are regulated by COMAR 102507. The MHCC is required to adopt emergency regulations to support the law. Caitlin and I will highlight MHCC's role and key components of the law. Next slide, please. So why are we here? There's enormous value in electronic health information. MHCC's longstanding interest in health IT comes from its statutory authority to develop an all-payer claims database and provide oversight to EHNs operating in the state. Widespread use of health IT improves the quality and effectiveness of care delivery and enhances population health by aggregating data can be used to identify and track health trends. Leading components of health IT include health information exchange, electronic health records, telehealth. Federal investments in health IT with the passage of the Health HITECH Act of 2009 has moved MHCC to a much more engaged relationship with stakeholders to maximize the benefit of health IT on care delivery. Next slide, please. HIEs enable the sharing of clinical records electronically among healthcare providers and between providers and patients. Sharing information electronically enables providers to timely access confidentially share patients' vital medical history where patients are receiving care and to provide more effective care tailored to patients' unique health needs. HIEs enable HIE entities operating in Maryland that meet the statutory definition of HIE must register with MHCC annually. 16 HIEs are registered with MHCC. This includes CRISP, the state designated HIE. Among other things, registered HIEs must have completed a SOC 2 audit or achieved high trust certification. Both focus on privacy and security controls designed to assure entities that protected health information is stored and processed securely. Maryland law aligns with privacy concerns of stakeholders. A 2011 law requires MHCC to adopt regulations governing the privacy and security of protected health information obtained or released through an HIE. Regulations were developed with support of a multi-stakeholder work group. COMAR 1025-18 became effective in March of 2014. Next slide, please. In August 2020, activities began to modernize and align COMAR 1025-18 with the federal 21st Century Cures Act, mainly the interoperability and information blocking provisions, and includes amendments to support state health IT legislation passed during the 21 and 22 legislative session. To assist in the work, staff competitively selected Post Shell, a law firm with a strong background in health IT and knowledge of Maryland federal privacy security laws. The MHCC's AAGs are providing guidance, drafting amendments, and in June, stakeholders were invited to provide informal comments on preliminary draft amendments to the regulations. Make the changes necessary to support the requirements of HB 812. Regulation modernization activities have been slowed and will resume once emergency regulations are adopted by the Commission as required by the law. Staff will discuss the emergency regulations later in the presentation. Next slide, please. EHNs, where, as noted, electronic health networks exchange electronic administrative transactions between payers and providers, and they complete payer-specific claims error checks, such as mismatched diagnosis codes, improper calculations, and coverage denials. Resolving errors before claims are transmitted to payers decreases the time needed for payers to process claims. COMAR 1025-07 requires payers that accept electronic transactions originating in Maryland to accept these transactions only from MHCC certified EHNs. To receive MHCC certifications, EHNs must be accredited or certified on a 2-year cycle by a nationally recognized organization where standards related to privacy and confidentiality, business practices, and human resources, technical performance, along with security measures are evaluated. Today, there are 29 EHNs that are MHCC certified. Next slide, please. I'll turn next few slides over to my colleague.
Great, good afternoon. So next slide, please. I'm going to briefly be discussing what the bill says. So House Bill 812 was passed in the 2023 session. It prohibits the disclosure of legally protected healthcare by an HIE or EHN beginning December 1st.
A second. I'm sorry. Could someone please go on mute?
Got noise from someone's speaker.
Is there to mute them from here?
They didn't give me any buttons, but please go ahead.
So the new law defines what legally protected healthcare is, which is all reproductive health services, medications, and supplies related to 1, the provision of abortion care, and 2, other sensitive services. Other sensitive services means reproductive health services other than abortion care as determined by the Secretary based on the recommendations of the Protected Healthcare Commission. This new law establishes the Protected Healthcare Commission. Next slide, please.
They're still getting feedback from someone's.
Put it on mute.
The Protected Healthcare Commission is charged with making recommendations regarding sensitive health services to the Secretary of Health and determining what is legally protected healthcare. So the bill requires that the Maryland Department of Health adopt emergency regulations within 90 days of the effective date, which was June 1st, to restrict the disclosure of abortion care and other sensitive health services. it requires this commission to adopt emergency regulations within 9 months of the effective date to restrict data sharing of patients who have obtained legally protected healthcare. The fines for non-compliance will begin June 1st, 2024, which are very high, and not to exceed $10,000 per day for violations of this law. And then it also mandates the commission to report on implementation, the progress of the implementation of these laws in 2024 and 2025. Next slide, please.
That would be the maximum fine, not a required fine.
That's correct, the max, yeah. So the Protected Healthcare Commission, like I said, is charged with identifying sensitive health services, information by diagnosis, procedure, medication, and related codes. When disclosure would create a substantial risk to patients or healthcare providers, they are permitted to consult organizations who have expertise in this area. They will issue semi-annual reports to the Secretary of Health to identify, again, sensitive health services. And then within 60 days of receiving this semi-annual report, the Secretary of Health will establish findings and determinations in a written response to the commission. So there was a recognition that this definition of sensitive health services and what codes are related could be a evolving process that changes regularly. And so this commission is charged with making sure that the definition and what includes it is up to date. Next slide, please. And then this just describes who's a part of this new commission: the Attorney General, their designee, this commission's executive director or their designee, and then you can go through the line of the specific appointments from the Secretary of Health. My understanding is that the commission is still being formed right now.
Not to belabor the fines, but the fining authority, is that this commissioner or is that the MHCC?
HCC.
Okay, that's what I thought. We are the enforcement agent.
Oh, fining.
Yes,
Findings.
I'm still stuck on the fines. I'm not really stuck.
Okay.
We're the enforcement agency though, not the EHCs.
Correct.
Although we don't get to keep the
Afraid.
money. General goes to the taxpayers. Right, yeah, right.
Next slide,
Okay.
please.
Okay.
Next slide, please. Want to talk about that here?
Sure. I got distracted by the question a moment ago. So for the emergency regulations, staff, we're working closely with our AAG to draft draft regulations changes to COMAR 1025-18 and 1025-07 support the bill, HB 812. Staff plans to propose draft amendments for commission consideration, seek approval for a 30-day informal comment period at the September commission meeting. Staff anticipates presenting the final emergency regulations for commission approval and consideration at its November meeting. And Caitlin. And next slide.
That's our goal. Yep. Next slide, please. Next slide. But then we thought it would just be worth mentioning to describe what's going on on the federal side related to reproductive health care privacy. On April 12th, 2023, the Office of Civil Rights issued a notice of proposed rulemaking to modify the HIPAA privacy rules to strengthen reproductive health care privacy. Just as background, the privacy rule generally establishes requirements with respect to the use, disclosure, and protection of PHI by HIPAA-covered entities. So this new rule, which was proposed, strengthens privacy protections by prohibiting the use or disclosure of PHI by regulated entities for either of the following purposes: a criminal, civil, administrative investigation against a person in connection with seeking, obtaining, or facilitating reproductive health care that is lawful, or the identification of any person for the purpose of initiating such investigations or proceedings. So what this is trying to do is protect actors from states who have banned certain reproductive health care from going after people in states that received that health care and trying to prosecute them. So it's banning releasing that information to these out-of-state actors when obtained that health care was lawful where they obtained it. So in order to implement the proposed prohibition, the new rule would require the regulated entity who is receiving the request for PHI to obtain a signed attestation that the use or disclosure is not for one of these prohibited purposes. So the comment period has closed. I know the Maryland Attorney General did sign on a comment that supported this proposed rule. So we're just waiting to see what the Office of Civil Rights will do next.
In terms of the comparison of the feds to the state sounds like it goes a step farther in terms of just projecting that it's really not, even if it was an in-state actor, it's none of your business who does abortions, who gets abortions, et cetera. Is that correct? Whereas the feds sound like it's more this, you know, I don't want Kansas to sue a provider in Missouri kind of stuff.
So.
It's not like we'll go away in this topic once the feds are done.
So speaking as a non-lawyer, as a matter of opinion, I think they both.
Ask a
are-
lawyer.
Ask-
Go ahead.
I think they're somewhat different and they have strength in different ways, like the authorization at the federal level is a little different than in Maryland, whereas you have to have a consent signed in order to exchange information to another treating provider, where the authorization functions a little differently. But by and large, I think Maryland's approach is more specific to how the information is obtained. What protections are around exchanging that information. And again, I'm not speaking as an attorney.
Yeah, it's a little bit different. I mean, our bill is talking about HIEs and EHNs and who can disclose information. The HIPAA rule is talking about covered entities. So those don't necessarily, you know, those are kind of talking about two different.
Right.
We were talking about this earlier, that we do think that our rules would cover what this expansion of the HIPAA is.
Well, I think so. I mean, the Venn diagram is kind of, I think you cover what they do and more.
I think that's
Okay.
how I would interpret.
No, it's not like it's going to be those, you know, where we start a state initiative and after a year, we just go away because the feds have preempted it. Okay, got it.
This may be built into the summary of the rule as opposed to what the rule itself is, but to the extent the federal rule prohibits sharing of information in connection against any person in connection with seeking, obtaining, or facilitating reproductive health care. I know that the case we envision is somebody going after someone who provides abortion services, but it also could be fraud investigations. Like, would fraud investigations also be like, you can't do a fraud investigation against a provider because that's in connection with reproductive health care? Should we be concerned that they've drawn that broadly to actually protect bad actors who want to get into that space now because it can't be investigated? Independent of the. Well, I'll rephrase it. If you look at the way this is, and maybe it's a summary here, if you're not allowed to seek an investigation in connection, like do investigations in connection with the provision of reproductive health care, it could be that it's a bad investigation that wants to penalize someone for getting an abortion. It could be an investigation as to whether the doctor is actually providing the services that were promised, or even providing the services at all, or providing them in a dangerous way, right? Like fraud investigations, quality investigations, you know, criminal misconduct investigations that are not about whether or not services should be legal, but about whether they were done properly. I'm just wondering, is there any concern out there about whether or not these regulations would inhibit those sorts of investigations that are really quality, you know, almost quality and consumer protection types of measures, independent of the agenda of what.
Or at
services
minimum, an
should be provided?
unintended consequence of the first.
That would be, that's what I was asking, but is that a concern, or is this just, no, that's just the summary here and
I
they
think
thought all that.
that's where I would go immediately, is that addressed in the detail in
Yeah,
the
that's
regulation
what I'm
and
getting
the
at.
summary, which is where you started.
It's always worth a second look, but I can tell you, starting with 18.2, it doesn't prohibit the exchange of information, of legally protected information for purposes of claims adjudication. So I think if you take what Commissioner Chair Sargent is saying a bit further, that if the payer wants to use that data that it adjudicated a claim with to look at issues such as fraud and abuse, it doesn't say that it cannot. It says that claim information can be used for payment purposes. So I would imagine a logical assumption is if payers paying for it, they may want to look at issues related to patterns that might raise a flag on fraud.
Yes, often those investigations lead to passing things off to the criminal authorities as well, and I would hate for that, you know, where there is actual fraud, for example, it becomes a criminal investigation. Okay, I would hate for the good purpose of the bill to actually make things more dangerous from respect for the people getting the services.
Right. Well, yes, and if you're at the federal level, if you're requesting the data, you have to sign, you have to sign attestation that says you're not using it for anything related to the aforementioned comment.
Right, because it has to be lawful, right? Like the reproductive healthcare that the person is either seeking or that it's help facilitating is lawful. So if the attestation says, well, it wasn't lawful, right? And here's maybe why, then they might be able to release that.
Yeah, I think there is a significant difference between the two, the state and the federal, in that information continues to flow unimpeded as conceived by the federal regulations, whereas in Maryland, information is impeded unless the patient consents, which is a tougher hurdle, and one that we are getting, you know, I think it's fair to say, we haven't released any proposed language to EHNs, EHRs, or HIEs, but we are getting concerned about the sophistication of their information systems. Can they block this but not that, et cetera, which we'll have to work through with the sectors, because I think most people that would seek this protection would not want to screen out all information, and clinicians would be concerned if all information was blocked. But it's going to be, at least during this period when technology hasn't quite kept up to the recognition that we need granular consent, not just for reproductive health, but there may be behavioral health services, drug treatment services that even people of non-childbearing age would want to shield from other providers. Those features are not in place either at this point. So stay tuned on this. I think ours is a more certain prohibition, but because it's more certain, it does present some problems with implementation. The feds, I think, are resting very heavily on this attestation document that would hold a sort of Damocles over anyone who would attempt to get this information for purposes not permitted regulations. Stay tuned. Seems like we have a lot of little squabbles going on these days.
Are there any other questions or comments?
Yeah, I just want to go on record that this is, concerning when you start parsing apart the information available at the point of care for electronic, from electronic health exchanges. It's, undermining the intent, purpose, and value of these HIEs. If suddenly you get something where you've got this partial disclosure of a medical record, then it's going to just really undermine the value that's been built into these over the years of creating them. And to me, as I do work in the emergency department, I do take care of unassigned obstetric patients, and have someone come in and not be able to know their history is concerning for what do you do in a case of emergency, or if someone's unresponsive and you can't get that information like you could other things like an appendicitis treatment or whatnot. So I just think that this is creating a level of danger at the point of care that's maybe not contemplated in this idea of this granular consent and so forth. And then the second thought was, if you include other reproductive services. I mean, is this gonna totally revolutionize malpractice for those of us who provide, you know, other reproductive health services? You know, if the patient's information cannot be used to, you know, sue a delivering doctor, what's the ramifications for malpractice and the associated checks and balances in there? So, you know, it seems a bit Pandora's box, but you know, I guess it's what we're left to try to work through.
Yeah, that's
We've
very good.
heard that comment.
Yeah,
I will note that the patient can give consent to release their own information. When that consent comes in, you know, it's something we're gonna have to kind of work through with the PHNs and HIEs through our regulations. So we'll post them for informal comment when we get them done. We'll see what kind of comments come in and we'll continue to keep the commission up to date on. getting his comments.
Can I echo your concerns? I think it's maybe time for me and you to retire.
I was thinking I was gonna get away scot-free on my malpractice premium if this thing goes through.
that's right. All of a sudden, there's no incident.
Well, I was
Hey,
gonna
no one
say,
can sue
that's
me.
the likely impact.
no
if the
bird.
Regulation
Yeah,
is
so-
interpreted as you laid it out, which would be helpful because that market is hardening to the point of lack of availability.
Oh, yeah. Oh, yeah.
So that concludes our presentation.
Thank you.
Mr. Chairman.
Thank you.
Nice job.
Very good. Well, that puts us at the last agenda item.
Yes, thank you. Stephen and David, and for, will not be meeting in August. Although the chair has the ability to override that rule. Hearing no
Unless I
comment.
hear a groundswell of opposition, I'm inclined to
No.
not have the August meeting.
We would meet in September and we do hope to have the Doctors Community Health CON available for commissioner action. That's a CON that would establish a new obstetrics program in Prince George's County. One that I think is broadly supported by the community. We would also hear from, we're going to hear from David on the interstate telehealth report. I guess Tracy's directing the music. There's no orchestra here, but we would expect to at least be able to comment with you on what we've heard on 10/24/01. Winnie said we wouldn't be bringing that back for further action, but we'll give you an insight into how much concern there is. That's an 80-page regulation or thereabouts. So there's a lot in there. It defines the entire, the procedures of the Maryland Healthcare Commission with regard to operations of health planning in the CON program. So not an insignificant amount of our work. I would expect that we would also have one or more other reports that will be going to the legislature ready for preliminary review in September. So enjoy the time off and we'll look forward to seeing you. I did also want to just bring it to the commissioner's attention that we will be holding an orientation meeting for commissioners that will take office in October. Now, we're making specifically for those commissioners who have not, had any experience, but if a commissioner wants to attend, please get in touch with me. I don't think we would be concerned about quorum issues because it will be held here, but it'd be good to know just the number of people that are interested. It will focus on our 4 major functions, health planning and CON. I'll probably run about 3 hours. Health planning and CON will take up 2 hours and 45 minutes. And the other 3 presentations will be, use the time available. Not really, but clearly, I think most of the commissioners here would agree that, having people aware of the scope of our authority in health planning is important. Moving back to that that Prince George's issue, there has been talk about, the Healthcare Commission needs to provide more beds in Prince George's County. We will be presenting in September our plans for incorporating health equity in the various functions of the commission. I know Chairman Sargent has been very emphatic that staff has to share with the commission plans moving forward. I would note that New York State recently did adopt some new rules regarding how they plan to use their facility planning functions in their health planning and activities. I'd also note that this concern in Prince George's County is real. They have talked about bringing that man from the MHCC down to talk about why beds, not sufficient beds were given to Capital Region. I'm assuming that's the chairman, or perhaps they're talking about Paul Parker or Bob Moffett. I don't know, but I'll find out and report back to all of you who that person might be. But there is some concern among the political leadership. But I think that we can be honest and say we call them as we see them. When the Capital Region was established, all the evidence did suggest that the size of the facility appropriately scaled to the needs at that time. I think one of the things when you're looking back through the prism of the pandemic, you do get shaped by things that we could not have anticipated. So thank you. Have a great time in August without the staff. And if you have any questions, by all means, feel free to get in touch with us. Thank you all for your patience today.
Thank you. With that, I'll take a motion to adjourn.
So.
All right. Have a great August, everyone.
All right.
Take care. Thank you.
We're adjourned.